Hello. I hope I'm audible to all. Myself, Dr. Onisha Vijay Kumar. I am a periodontist and aesthetic dentist who is based in UAE, and I will be chairing today's session for the virtual conference. A very good morning once again to everyone present here. It gives me immense pleasure to welcome you all to the day three of the fourth International Advanced Dentistry and Oral Health UCG Conference and the 16th International Healthcare Hospital Management, Nursing and Patient Safety Conference. Over the past 2 days, we have shared remarkable insights, groundbreaking research, and meaningful collaborations across various domains of dentistry and healthcare. It is a true honor to address this distinguished gathering of professionals from around the world. This Congress exemplifies how collaboration and knowledge sharing can spark innovation and drive progress across our fields. It is truly inspiring to witness experts in dentistry, oral health, healthcare management, nursing, and patient safety come together all on one platform to exchange ideas, share innovations, and highlight best practices. At UCG conferences, we remain steadfast in our commitment to advancing these noble professions. As healthcare and dental professionals, we hold the vital responsibility of improving patient outcomes, strengthening systems of care, and shaping the future for healthcare delivery. In today's fast evolving world, this responsibility is more important than ever. Let us make today as impactful and inspiring as the days that came before it. And I wish all our lovely speakers and participants a highly productive and successful day ahead. Without any delays, I would like to begin our today's conference. And our opening speaker this morning is Ms. Leila Al Ahmed from King Fahd Medical City in Riyadh from Saudi Arabia. So she specializes in emergency medical response and critical care recovery. Her speech is titled Connecting Critical Care to Continued Recovery. So, once again, please join me in welcoming Ms. Leila El Ahmed.
Hello, good morning. Thank you, dear, for introducing me. I am Leila Ahmed. I work as head of the inpatient order system section and the electronic medical record. It's honor to be part of this um, conference. Um, Also, I would like to thank the organizer for giving me this opportunity. Actually, I am passionate about using technology to support the healthcare provider and improve the patient outcome. Um, can you see my screen?
No. Yeah, now it is.
Okay, good. Okay. Um, Inshallah, today I will talk about the connecting critical care to continued recovery uh, and how we can bridge the gap between the intensive care and long term recovery during our system to ensure that every step of the patient journey is supported with the right tools, technology, and collaboration member. Uh, in in the beginning, our system, each team has their own documentation, but there is no integrated between them. So the physician will write his note, the nurse will write his note, and after discharge, the clinic will take their on work, but there is no bridge between them. So we start our project, critical care, um, 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 for minimize this gap. So we generate report depending on exclusion and exclusion criteria verification, uh, and multi-disciplinary team documentation, standardized assessment parameters in the outpatient and in the patient during the ICU, a free text, a clinical impression. The critical advanced recovery enhancement workflow start in the two main elements. It started during the admission. The admission should be more or above 14 years and within 24 hours of ICU admission, and a batch score should be above 50. The other element should be ICU length of stay more than 72 hours in ICU. The inclusion criteria should be mechanical ventilation more than 72 hours, first time non-invasive ventilation, polytrauma, septic shock, acute respiratory distress syndrome, acute hemorrhage requiring massive transfusion, major post-surgical complication, and ECMO. The exclusion criteria should be DNR or brain death, active chemotherapy, complete the daily living activity dependency. Uh, the glaucoma score should be lower or equal to 12 or progressive neurological disease, baseline congenital dysfunction, and if there is any exclusion criteria are met at any point, the patient is excluded from our project. The critical advanced recovery enhancement workflow from hospital to clinic, the care team follow up, daily multidisciplinary follow up until hospital discharge by ICU physician, nursing practitioner, respiratory therapist, physical therapist, occupational therapist, pharmacist, and case manager. Hospital discharge, patients are screened and a critical advance recovery enhancement clinic appointment is requested in our system. Clinic protocol, first visit should be during the first month after discharge, whether is in person or virtual. The visit should be from 3 to 4 visits per the year for the follow-up. The multidisciplinary collaboration should be between the physician. The physician will be medical assessment, diagnostic, impression, treatment plan, modification. The nurse practitioner will take care of the assessment, symptom management, and coordination of care. The pharmacist will be medication reconciliation, drug interaction, therapeutic adjustment, respiratory therapist, pulmonary function assessment, oxygen requirement, breathing exercise. For physical therapist or occupational therapist, functional capacity assessment, mobility recommendation, and activity daily living support. The case manager is the end of our cycle our chain. This is will be helpful to resource coordination, discharge planning, and ensure navigation. And the end is the follow-up requested to clinic. The ICU summary documentation, length of stay should be versus the date and duration. The ventilation details like the mood, duration, weaning process, the advanced intervention like the ECMO, CCRT, VAS process, complications like the VAB, Drilum, pressure injury, nutrition is internal or parental support details, sedation is agency, duration, and withdrawal symptom. A clinical assessment parameters like the vital signs, Glasgow, comma, skull scar, wound healing process, pain assessment using standardized scales, and functional status and mobility matrix. In the clinic, in the clinic visitor workflow, the nurse will do the assessment, write the vital signs, wait, and check the medication list verification and chief complaints. The physician consultation, review the finding, development of follow-up plan, specialist referral as needed if they need any other teams to help. Multidisciplinary evaluation, the nutrition assessment, physical therapy evaluation, wound care assessment, social work consultation. Nursing examination, nursing practitioner examination, post intensive care syndrome, and assessment and physical examination, congenitive screening. The pharmacist review the comprehensive medication reconciliation, adherence assessment, and side effect evaluation. The care clinic use a hybrid model along for both in-person and virtual visit to maximize accessibility while maintaining the comprehensive care standards. The implementation impact and the benefits of the CARE project. The implementation, health information system integration. We custom designed by ICU team with IT support to ensure seamless workflow integration, improve data accessibility, structure field, enable rapid retrieval of critical information during follow-up visits, enhanced clinical decision support, automated alerts for uh, concerning trend in the vital signs or lab value. The benefit of the CARE project is continuity of care, a bridge information gap between the ICU and post-discharge setting, early intervention, facilitate early detection of post-ICU complication and readmission risk factor. Patient-centered approach, aligning the treatment goal with patient and family preference and need. The future direction, we hope to expand our implement like adapt care note module for other critical care units and specialized departments so will be easy to connected with them after discharge the patient. Research application utilize structures data to investigate post ICU outcome and recovery path, continue refinement, retrieve improvement based on user feedback, and emerging clinical advance evidence. Sorry, integration enhancement, develop interface with other hospital system and external healthcare provider. The systemic collection of both ICU data will help improve the quality and mentions the hospital protocol for critical care and follow-up visits. In the conclusion, the bridge, the care continuum, the K achievement, successfully integrated structure post ICU documentation into health information system workflow, establish clear criteria for patient inclusion and follow-up, created standardized multidisciplinary assessment framework, implemented hybrid clinic module to maximize accessibility, developed comprehensive data collection for quality improvement. By connecting critical care continued recovery through the structured documentation and multidisciplinary team collaboration, the care project enhancing patient outcome and provide a valuable data for ongoing improvement, either for the research or for the quality of the hospital. Uh, now, any question?
Thank you so much, Ms. Leila Alamid. I would like to just ask you something regarding what are you talked about the critical care, the possibilities that is possible in a hospital. So, what are the challenges that you actually face in implementing this?
um, there is a resistance from the end user, because they think if they share all this information, they think it will take their time. But we try to adjust it to be, uh, and there not to be multiple choices or less that easy to catch their information without write everything, but
Hmm.
contain all the information that will help other team and the clinic.
Okay. Do you think it is more easier, like when it comes to probably a clinical setup with multidisciplinary, like something like that, or in a huge hospital setting that, this is more possible?
I think so. Yeah, they can do. Our hospital is city, it's big hospital, and it's uh it's work good, but still it's just only for the intensive care. So we hope
Okay.
to expand our project to all the critical other care, but they need time. They need time from building
Oh,
a system and training for the end user. But we can do it.
okay. The floor is open for any questions. Does anybody, any delegate have any questions? Please feel free to ask her.
I don't have a question, but I have a comment that I give kudos to this project because although it looked like it's going to be a big project, it's wonderful that you are doing that and looking at, readmissions, risk factors for readmissions to the hospital. That is encountered by every hospital, I believe, whether you're large or small or have intensive care units that are huge. And I commend you for this project.
Thank you so much, dear.
Any other questions or comments? I hope there are no other questions. Then, once again, thank you so much, Miss Laila Al Ahmed. It was a wonderful presentation. We got a lot of insight into your project. Thank you so much. Next,
Thank you, dear. Thank you.
next presenter we have is welcome the next speaker, that is Dr. Sana Al Rubai from Iraq, a periodontologist and dental implantologist at Gum Health Clinic. Her expertise lies in advanced periodontal care and implant dentistry, and she will be presenting on the topic effective communication in dentistry. So, join me in welcoming our next speaker, Dr. Sana Al Rubail.
Good morning, everyone. My voice is clear, okay?
Yes, it is. Yes.
Thank you very much. Thank you. Today I'm going to discuss about the effective communication in dentistry. I have published a new book about this subject, which is written in Arabic language till now, not had been translated to English because it has been published in February 2025. Under the title of The Art of Interviewing in Dentistry. I wrote about the patient-centered approach in dealing with our patients at the clinic. Let me start with how are communicating to each other nowadays from the past, how the communication has been changed from the past to the day. As you know, we used in the past, we used to gather in the living room, talking to each other, gathering information, exchanging, knowing each other's information or problems. Also, we were sharing feelings, hobbies, hugs. But nowadays, when we have the electronics, the immobiles in our hands all the time, 24 hours, even sleeping with us, we became to chat with our mobiles. We trying to be together with our mobiles, eating our breakfast and lunch with our spouse, even with our mobiles. And also, we have the rest and having the break time with our work colleagues, with our mobiles also. We became more electronically connected than connecting as an individuals, as a people. We lost that talk, we lost that expressions, the eye contact. It was it is a modern life. This is the modern life. How does that affect us? Microsoft company had made a research on in 2015. This research showed that the human attention span has been decreased about 25% from 2000 study, the year 2000 study. It became 8.25 seconds. What does it mean? And why is that? Because of the vast information that we are receiving nowadays in our hands, with our mobiles, with our tablets. Our brain trying to tackle those informations. Once one information came, the another one come. It's distracting. While we are trying to work, there is a message in the WhatsApp, message in the LinkedIn, and in email. It needs to be processed. A vast and a huge amount of informations and new informations, interesting informations, well done and well presented information, attracting our attention. Think less patient, selective listening when we're talking to our colleagues or our family. I need to hear the word that I need to hear it. I'm impatient to listen to you, not anymore. Also, we are not just caring about the fine informations that make the difference in our communication, make the difference in our interactions with each other. We became introverted. Don't you agree with me? We share less information. We share, um, we don't know how to express our feelings, our fears, our love, our attention. It's very important. And me as a dentist, I'm a human, and my patient as a human, living in the same environment, living in the same era, the electronic era. We both have this short attention span. How can we deal with each other effectively in the dental clinic? Patient has suffers. I have my own work and information. I need to translate these informations to him. I need to hear from him. But at the same time, I have a short attention span as much as him or his. So how can we achieve that effective communication? I wrote in my book about the empathy, which is the golden standard in communication. Also, I presented the verbal and non-verbal communication skills, which not most, all the dentists should master them. Also, we have to know how to deliver the bad news to the patient, dealing with him as a human, not the diseased one, as a human, as my friend. Learn how to manage the patient's fear, how to manage the patient's rejections. It's very important in the dental setting. What makes this dentistry differ from the other fields in the medical care is that most of our patients came to the clinic suffering from a severe pain. Severe pain elevates adrenaline, makes him more anxious, bring the bad experiences, bad past experiences in front of him and make it difficult to deal with. Also, maybe the unexpected financial load will be on him due to the elevated prices of treatment. It's all bring a psychological effect on him. It's a very complicated field to deal with. Dentistry is not easy. So by presenting the patient-centered interview, which focus on the patient as a human, it deals with feelings, suffering, thoughts, expectation of the patient from his visits, the need of the patient. What does he need now, right now? Is it correcting the function? Is it correcting the aesthetic aspect or the aesthetic smile? Or is that pain which make him not sleeping the day before, which is needed to be treated right now? It's very important to know it. Also, the patient-centered approach make the patient as a partner in his treatment. He or she has the right to choose the treatment option to be done. It's not the disease-centered interview that we used to have in our clinics as we studied in the dentistry schools or even the medical schools for the past 20 or 30 decades before. We have to tackle or manage the patient as a human having a disease, not to manage him as a disease in a person. We have to look for the human before his disease. This can be achieved through the Galgary-Cambridge guide, which divide the interview into 5 sequences, 5 different phases. First of all, I have to build, which is the most important patient, how keen I am to make my patient the most comfortable and the most compliable patient, and how I became the keen and the dentist number 1 for that patient, that particular patient. It's very important. It's beginning from saying hello for the patient, for introducing him to the dental set, begins from preparing the environment for this interviewing, how comfortable is my clinic is. I'm not going to interviewing him in a cafeteria or in a garden, which is a relaxing one. It's a dental clinic. What color of the walls I should choose, where to put the maybe the plant, the pictures, what kind of pictures I put on the walls of my clinic. It's very important. Where to sit, how can I sit, what is the body language of me to present my welcoming for him, how to communicate comfortably with him, how to show confidence and to make him relaxed. You are in the right place. This is very important. Then came the phase of information gathering. I should listen attentively, not selectively, attentive listening to every single information he can give. By what? By asking him the open question. How can I help you now? How can I help you today? What is bothering you? He begin to express his problem. How does this problem affect his life? What does it mean for him? What is the expectations of him about this problem, and how I'm going to solve it? What kind of a treatment does he need today? It's very important. Also, we have to know the medical history, and we have to search between the lines that he said. We have to search if there is any fear, if there's any anxious words he can express. We have to tackle that. We have to know it, to know with whom I'm dealing with. I used to tell my colleagues in my training courses that when a dentist, when a patient came to the dentist should keep in mind that he is interviewing 2 persons, not 1. The one that he lies in front of him, okay, and the one that's hidden, the one in the past. The bad memories may jump up accidentally. You don't know how. Maybe from the voice of the turbine hiss, or maybe from the smell of the clinic. You don't know how the memories came back and make the patient practice differently, show another person. You don't know. So you have to know that information, or the bad experiences that he suffered from. And then we came to the clinical examination to see what is the problem. And after that, we came to put all the information we have gathered with what we have seen in the physical examination and put it on the table discuss it together with the patient. You have this problem, this is the cause, and this is the effect. We have the treatment options 1 and 2, 3, which number 1 has this cause and pros, number 2 has this cause and pros, and giving the patients the right to discuss what he needs from them, what is the preferable for him, what kind of treatment, what option that he prefer to be done. Okay, and he have the right to discuss them. We have to listen for every single question he can ask. And then after that, we came to the shared decision making, shared the treatment plan. And before we ending our interviewing, we have to discuss or review all the interview we have made. You came with this pain or this problem, we discuss, we examine, and then we discuss the options. You choose one, choose number 1 maybe. This is the alternative, and then planning for the next visit, when and what will it be. If there is any uncleared idea, if he has any questions, you have to make sure that when your patients say goodbye, he has a clear story of his problem and his treatment plan. Through all these 5 phases, dentists should keep mastering the verbal, non-verbal communication skills. His ergonomics should keep them all right to maintain and develop the robot that he tried to build at the beginning of the interview. So building robots is the first and the most important aspect we should build with our patients. How? By, first of all, try to take care of your greetings, how you are welcoming your patient. Treat him as your friend. How are you going? How does we welcome our friends? Okay, how you prepare yourself for interviewing your or seeing your friends? It's the same with your patient. Also, the active listening. It's very important. You have to keep silent while your patient is talking or telling his story. We have to keep listening. How? Just listen. Just grab those informations, even the fine one, and not try to think of the next question you are going to ask. Please, just gather information and then try to categorize them in your mind. Not, again, do not think of the next question to be asked. Just listen. And then you have to communicate clearly with your patient. Avoid the jargons, avoid the technical words. Just talk normally, just talk in his language, in his simple language. If there is any cultural differences, you have to tackle them. You have to be simple. Your patient is simple. He's a human, not as keen in dentistry as you. So clear communication. Also, we have the personal connection. Ask him about his life. If it is feasible, if it is okay or allowed in your culture or community. Ask him about his son, his girl, how the study is, what is his interest, his favorite book, maybe. This can make the robot more stronger. Try to make common hobbies between you and him. Okay, then the address the anxiety. Once you feel that your patient is not feeling well, not feeling rest, you have to mention it by saying, I see you are anxious. I see you are not comfortable. I see you are have not slept before, the night before. You have to focus on or keep the light on this. By this, you are proving to your patient that you are caring about his feelings, his suffering, more than his disease. This is the core of patient-centered interview. Okay, and then involve your patient with your decision. And try always to ask the patient, ask the permission from the patient. Before you examine his teeth, you have to ask his permission. Can we examine your teeth? Can we see this today? Can we do this today? Always take the approval from him before you start. Avoid open your mouth. Do not talk. This is not acceptable nowadays. It's inhuman. Okay, the golden standard, empathy. What does it mean? It's simply by putting myself in his shoes. This is simple empathy. How can I listen to the untold words? How can I feel the unseen dialogue or unseen condition? How? This is empathy. How can I be empathetic dentist? Again, listening. It's very important. Empathetic listening, active listening. Just show him that you are giving him all the attention, your ears, your head, your brain. You are with your patient with every single information that he is given. And then try to understand his feelings, why he's feeling anxious, why he's feeling unhappy, uncomfortable. And if you were in his place, are you going to feel the same? And this is the reflection. Sometimes we remember past experiences of our and say, yeah, when I was in his place, or when I suffer from my experiences, my past experiences, I felt the same as him. This is reflection. And by doing these 3 steps, we are showing empathy to our patient. How can he feel it? It can be seen in your expressions, your eye contact, your gestures, your hands, by tapping on him, by nodding. You are understanding him. This is how you can show empathy to your patient. In dentistry, we can make use of ergonomics. It's very important and very strong one to show empathy. When dentists sit in 8 o'clock or 9 o'clock position, we can communicate with our patient. We can listen and give information. But when we sit at 10 o'clock or 12 o'clock, we are giving comments, which is not appropriate in communication. It's appropriate for work. Just open your mouth, close your mouth. Is it hurt? Just commenting. So when interviewing our patient, we have to sit in this area, the 9 or 8 o'clock. It can achieve the direct eye contact. It make the level of the dentist the same as the patient. They can feel they are equal in the right and in the talk. So this is important. Avoid this posture. Avoid looking at your patient from behind. It can make him anxious. And at last, in this slide, I summarized the most 7 mistakes that most of the dentists do and should be aware of it. First one is the jargon or the technical talk. Avoid using the medical phrases like granuloma. What does a granuloma mean? I'm as a patient, I don't know what does it mean. And instead said elevation or overgrowth of the cells, okay, or swelling, not granuloma. How good they are at dentistry delivering. They used to show their successes. I made hundreds of dental implants. I made such chrome cobalt dentures. Does it matter? I'm a patient. I have a pain. I need my pain to be solved, to be relieved. So avoid talking about how keen you are in delivering dentistry. Let your work speak louder than you. Not understanding the patient's need. When patient came with pain, he's not ready to hear from you a treatment plan that can solve the aesthetic part of or aspect of his face. Not allowed. He will not listen. I have a pain. I have a curious tooth. I need to be treated. Maybe the next visit you can discuss the aesthetic, how you can make the Hollywood smile for him. Also, most of the dentists not caring about building the rapport with patient. He's dealing with the patient as a numbers. I have treated 180 patients in the past year. No, patients are not numbers, they are human. So please build that rapport with your patient. Also, they cannot, or most of them cannot handling the rejection of the patient. Why? Because not giving the right of the patient to the patient that he has the right to choose the treatment option that suits him. Not investing time in building relationships. Again, the rapport with your patient. Keep following your patient. It's very important. When he give you the trust and you give you the chance to treat him, you have to follow him, follow up him to see how it was going. When you made a surgery for him, you have to keep following up him. Is there any problems? Is he feel good? It really counts for him. Treat him as you are the patient. The dentist is a human. One day he will become a patient. How you want your dentist to care about you or to deal with you? It's the same for your patient now. Also, the most important one is not listening attentively. They used, or most of the dentists used to listen for the one specific word they want to hear. Thank you for listening. I'm ready for your questions.
Thank you, Dr. Sana. I think it was a wonderful presentation. I think it was very, very clinically applicable to so many clinicians. And a clinician myself, I can obviously understand the importance. Many people always, they think the treatment part is the most important thing. But I do believe that the first is how you communicate with the patients. Again, a wonderful presentation, Dr. Sana.
Thank you very much.
Yeah, the presentation is open for any discussions or questions. Please do ask your question to Dr. Sana.
I agree that communication is so important, and you did a wonderful job in presenting that. And I commend you for taking that upon yourself to know that the treatment isn't the only thing, it is the communication. So thank you.
Thank you very much. Yeah, most of our problems nowadays, as a people, not a dentist, keep medical care away now. As a whole, our problems, it's all about communication. We are not trying to understand each other. Everyone has his own opinion, and that's it.
It's
Yeah.
very true. It's very true. And I think what you talked about, the gadgets and everyone getting so much involved in that rather than the human, the normal way how to communicate, that is lost in families, lost in among colleagues and everything. And I totally agree with you on that, doctor.
Yeah, it's
Anyway,
all because of the electronics.
yes, yes. The world is changing, and I
Yeah.
hope people do understand the importance in communication and they switch back or spend at least a little time in this, right?
Yes, yes, I agree.
Yeah,
Thank you very much.
yeah. If there are no more questions, I think we'll move on to the next one. Thank you again, Dr. Sana, for
I
the
have a
insightful presentation. Yeah, please do.
Yeah, sorry to interrupt. Yeah, so
No problem.
I have a question from Dr. Sana. So first
Yes.
of all, thank you, Dr. Sana, for this insightful talk about communication in dentistry, especially for like early practitioners like me. It was a very important aspect of dentistry to be talked about. So my question for you is like, what's your advice for handling situations where a patient refuses necessary treatment, or if we are delivering a bad news, like we are going to talk to them about an expensive treatment? So how should we handle that situation?
Yes, you have just mentioned the three problems. First of all, the rejection. The most important point to be kept is that do not make that rejection is against you as a person. He has the right to choose the most appropriate treatment option for him. From maybe time of the visit not suitable for him, maybe the cost, maybe many other many aspects we can face in dental work. So give him the right and admit that right. It will make it easy for you when your patient rejects your treatment plan. Okay. The second one you have said, the breaking bad news. It's a very important and big issue in dealing with in dentistry. First of all, for any person, when you face or hear some news not suitable for you, or you are not ready to hear for now, maybe let's take extraction of a tooth. For the dentist, extraction is the routine and daily practice he can make, and it's very easy. We can extract this tooth and put a dental implant in it, or replace it by fixed appliances, and so on. It's very easy for the dentist. But this news or these news are difficult for the patient. He's going to lose one of his precious teeth in his mouth. It will affect the function. It will affect the aesthetic maybe. So it's a very annoying news to be heard. It's very important to make it easy for him to deliver the information. You have to keep in mind that when he listen or hear that information, he will reject. So you have to prepare yourself for his rejection. It's his right also. It's the right of the patient to reject the treatment. Okay, give him the time to reject. Give him the time to express his reasons for rejection. Just listen from him. Just show the respect for his opinion. Okay. By time, it will take maybe 5 minutes, or maybe differ from patient to patient. You can tell him that you can go to home, discuss the issue with yourself and your family, make your decision. You can take this medication to alleviate your pain now, and came in another visit to treat that tooth. Now you are give him the right, or give him the ease. I'm not in a hurry to extract your tooth. It's okay to keep it right now. Okay.
Okay, yes.
Yeah, and then he will obey you or come with you. If you were in my place, what will choose when you choose the right and the appropriate treatment option? By saying, if you were one of my family, I will choose this option. This will give him the trust or give him the confidence to choose your countries not having the insurance for dentistry work, dental work. So, first of all, try to make it in a part for him. Just divide the price for him. Maybe it can make it easy for him. You can choose the most appropriate option for him right now, okay, and postpone the other
Yes.
expensive treatment options. Or you can if the patient is can pay but not quite sure it's the most appropriate solution for him, you can explain the treatment's objectives and the benefits he can get through the next 10 years. He's not going to pay more. He will forget this problem, just like an investment. It's your teeth, it's your appearance in the your culture or in your work. It's worth to work with or invest in. So by knowing your patient's interest and your patient's what can I say, uh, perspectives, make it easy for you to discuss these matters.
Thank you so much. It was very helpful. Thank you.
Thank you. Thank you. Thank you for the question. Thank you for Dr. Sana. Okay. Now we'll swiftly
Yeah,
move on
thank
to the
you.
next presenter. So next is a post.
Also, I need to mention that this have, yeah, thank you.
Thank you, Doctor. I would like to welcome our next poster presenter, that is Dr. Surbi Sakchi from India. Her clinical case study highlights unique diagnostic challenges in dentistry. So her poster is titled Aesthetic Management of Post-Orthodontic White Spot Lesions Using ICON or Icon Resin Infiltration, a clinical case report. Please join me in acknowledging our Dr. Surbi Sakchi.
Yeah. Thank you, Dr. Anisha. Please allow me to share my screen. I'm sorry, I'm not able to switch on my camera. However, I'm trying to share my screen.
Okay,
Yeah, for that I would have to rejoin. So I'm just trying to share my screen to start the
no problem,
presentation.
Dr. Surbi.
Yeah.
Yeah, you can try again.
Are you able to see my screen?
Yes, Dr. Sulbi, you can start
Okay,
with the
I'm so sorry
presentation.
for
Thank
the
you.
glitch. Yeah, okay.
No issue.
Yeah. Good morning, everyone. My name is Dr. Surbi Sakshi, and today I'll be presenting a clinical case report on the aesthetic management of post-orthodontic white spot lesions using icon resin infiltration. I would also like to acknowledge my co-author, Dr. Shipali Singh. She's an MDS resident in the Department of Endodontics. Okay, so let's start with the basics of white spot lesion. White spot lesions or WSLs represent the earliest visible stage of enamel demineralization. They appear as chalky, opaque areas due to changes in enamel porosity and refractive index. These lesions are particularly common following fixed orthodontic treatment where plaque retention is high, and the reported incidence ranges from 46 to 73% of orthodontically treated patients. So traditionally, we have non-cavitated lesions can be managed with preventive or minimally invasive therapies, but conventional approaches such as fluoride, CPP, ACP, microabrasion, and veneers, they have their own limitations. This is where icon resin infiltration provides an interesting alternative. Okay, so let's briefly revisit the etiology of white spot lesions. Orthodontic appliances create niche where plaque accumulates, and that limits natural cleansing by saliva. And that is how cariogenic bacteria like Streptococcus mutans and lactobacilli metabolize the sugar, producing acids. When the pH drops below the critical threshold of around 5.5, that's where enamel begins to lose calcium and phosphate ions. So this demineralization process manifests clinically as visible white spot lesions. And if it is left untreated, it can progress to cavitation. So the aim of this case is to present the use of icon resin infiltration for managing post-orthodontic white spot lesion. And we are going to highlight its clinical steps, outcomes, and the educational value. Our patient was a 20-year-old female who had completed fixed orthodontic treatment 1 year earlier. Her chief complaint was mainly anesthetic appearance of her teeth. So she had white patches on her upper front teeth, which significantly affected her confidence in smiling. The medical history was non-contributory, and there was no history of trauma or fluorosis. Her primary concern was arose after debonding of her orthodontic brackets. So on examination, multiple non-cavitated white spot lesions were noted on the labial surface of her maxillary anterior teeth. The teeth were otherwise healthy. There was no sensitivity present. So the diagnosis was post-orthodontic white spot enamel lesions. They were non-cavitated and according to ICD-AS criteria. Okay, so at this stage, we considered the following treatment options: fluoride therapy and CPP, ACP, which is present in the form of tooth mousse or Remin Pro. They can promote remineralization, but they require high patient compliance, and they rarely deliver predictable aesthetic results. On the other hand, microabrasion, it can mask lesions very effectively, but it is irreversible because it involves permanent enamel loss. And veneers or composite, they provide immediate coverage, but they require significant tooth preparation and compromises the sound enamel. In contrast, icon resin infiltration is minimally invasive. It requires no anesthesia, it preserves enamel, and it also produces immediate aesthetic result in a single visit. So why icon resin infiltration? The main strength of icon lies in its resin refractive index, which closely matches that of a healthy enamel, because the refractive index of icon is 1.46 and the refractive index of our healthy enamel is 1.62. So by penetrating the microporosities of the lesion, icon can easily block light scattering and it effectively masks the lesion. At the same time, it also seals the lesion and arrests further demineralization. So for this patient, icon was the ideal choice of treatment because she wanted immediate and aesthetic results. She wanted a completely conservative treatment without removal of enamel. and it was also cost effective for her, and it delivered results in just one appointment. So we'll go through the clinical steps. So in the first step, we etched the enamel with 15% of hydrochloride acid gel for 2 minutes, followed by thorough rinsing and then drying with a 3-way air syringe. In the second step, we applied Icon Dry, which mainly contains 99% ethanol, and we for 30 seconds. So the main role of ethanol here is that it displaces water and it simulates how the lesion will look after resin infiltration. So yeah, but in this case, since the lesion was only partially masked at this stage, we repeated the etching step for another 2 minutes and we re-dried it thoroughly. In the final step, we applied Icon resin. It's a low viscosity Tech DMA based material, and it was applied using an applicator for 3 minutes to allow deep penetration into the porosities created by the etchant. It was light cured and then followed by a second application for 1 minute, which was again light cured. Finally, the surface was polished, to achieve a smooth finish. So you can see the results. The outcome was highly satisfactory. White spot lesions were effectively masked, creating a harmonious smile. And at the follow-up, the results remained stable. There was no sign of relapse or surface deterioration. The patient reported being very satisfied. There was no post-operative sensitivity found. So let's discuss the mechanism of action of Icon. So from a scientific perspective of Icon, Icon works by infiltrating resin into the microporosities, which then alters the optical properties of enamel. So the lesion blends with the surrounding tooth structure. And additionally, it also creates a diffusion barrier, which further prevents the demineralization of enamel. This dual mechanism explains both the immediate aesthetic improvement and the protective effect against lesion progression. Now we'll talk about the advantages and limitations of Icon. The advantages are clear. It is minimally invasive. It preserves enamel. It requires no drilling, no anesthesia. It is definitely cost effective compared to veneers or composites, and it has a very high patient acceptance rate. However, there are limitations. Icon is only effective for non-cavitated lesions. Deeper lesions may not achieve complete masking, and although short and medium term outcomes are excellent, still the long-term stability beyond 10 years are under evaluation. So we'll talk about the clinical significance and learnings here. In conclusion, white spot lesions are one of the most common aesthetic complications that we encounter after orthodontic treatment. It affects up to 73% of patients. So Icon resin infiltration is a safe, effective, and particularly valuable when aesthetics are the primary concern of our patient. It fills the treatment gap between preventive and restorative approaches by simultaneously masking the lesions, and it also halts the progression of the lesion. With its painless and immediate result, I believe that Icon deserves strong consideration as the first line treatment for non-cavitated white spot lesion. Because we achieve a combination of lesion stability and aesthetic masking. So this case was supported by multiple studies, including systematic reviews and long-term clinical trials that validates the durability and effectiveness of Icon. Thank you so much, everyone, for your time and attention. I welcome any questions.
Thank you, Dr. Surbi. It was a wonderful experience knowing about this new product. I've not heard about it. So I just want to ask about the white spot lesions as such. Okay. Oh, thank you. Your video is now visible.
Yeah, I was trying since long. Sorry.
Yeah, it's okay. It's okay.
Yeah.
So I have a doubt that I don't know whether that will be also considered as white spot lesion, but once after the orthodontic treatment is completed, right, you remove the brackets. And that time there is a small correction. Obviously, there is composite that is attached to the tooth, and you slowly try to chip off this composite. I have heard, and personally also I have undergone orthodontic treatment, and after that there will be either it's too much of chipping of the tooth also with that composite, or a little bit of composite is left behind. Can you just elaborate on what is the issue over there? Can that be compared to the white spot lesions that you discussed?
So if we are talking about white spot lesions post-orthodontic treatment, we are mainly addressing the incipient lesions. They are mainly
Okay.
chalky appearances. Yeah, they are mainly
So
chalky
it's the
appearances.
pre-caries, right? It's
Yes,
about
yes,
to get.
correct.
Okay,
Yes,
sure.
correct. It's the precarious stage.
Okay.
Yeah.
It's not related to the composite removal after the bracket
No,
removal that is there. It's not that. Okay.
no, yeah, sorry.
One more thing I want to ask is that obviously you're not creating any, there's no cavity preparation or anything like that. You're
Yeah,
just etching and then applying the resin. Will it
yes.
be bulky by any chance, or is there measure? Will it look a little bulky?
No, so as per my case report, the appearance of the enamel of the patient, there was no bulky appearance. Also, because the role of this resin is mainly to infiltrate into the porosities, it's just optically blend into the enamel. So there's no bulky appearance.
Okay.
It just feels like natural enamel. So yeah,
Okay. So
yeah.
it won't be bulky. Like
No,
it
no,
won't
it
create
won't
a
be bulky.
problem in the aesthetic is more of
Yeah,
like it is. Okay, sure.
yeah.
Anyway, thank you, Dr. Sulbi. I would like to open the presentation for any questions, any queries. Please, if you have anything, please do ask Dr. Surbi.
Sorry, Dr. Eliza. I have a question.
Yes, doctor.
Yes, thank you for your nice presentation. It's very interesting one. I just wonder if the resin going to changes the color through by time. Is it okay?
No, so far with my patient, after following up with her, there was no color changes. The color stability was totally achieved. And in case it happens that in any case, if the relapse occurs, like if you see any kind of discoloration or the color is not stable, it is recommended that you can reuse it. You can reuse the resin. You can re-etch it
Reuse
and reuse it. Yeah. But so
etching
far,
over oh,
yes, sorry, so far with the research and the articles that I have gone through, there's evidence about 6 years of stability of this resin.
uh-huh.
Yes.
The second application will be etching the present resin or remove it by burrs and then etching the tooth surface.
You can just re-etch it, like you can just remove it and like reapply everything. Yeah.
Uh-huh. Thank you very much.
Yes. Yeah. Thank you so much for the question.
Any more questions, please? If there are no more questions, again, thank you, Dr. Surbi. It was a great insight
Thank you.
into the post-orthodontic therapy that we can do. Thank you so much.
Thank you so much for
So
giving me this opportunity.
you're welcome. Thank you. We'll be moving on to our next speaker. Is Dr. Minerva Kelada. If I'm pronouncing it right, please forgive me. Dr. Minerva, are you available right now? I think Dr. Minerva is not available right now. I'll be moving on to our next speaker, Dr. Takeshi Suruta. Our next speaker is Dr. Takeshi Tsuruta.
Hello.
Good morning. Good morning, sir. He's a biomimetic restorative dentist from Japan. He has contributed innovative restorative techniques in dentistry. He will speak on the topic, a novel isolation technique using polytetrafluoroethylene tape and split dam isolation for cementation. Over to you, Dr. Takeshi.
So let me see. Can you hear me?
Yes. Yes,
Okay.
your presentation is visible.
Okay. Mm. Okay. Can you see my presentation slide?
It is clear. It is clear. You can start.
Okay. Hello, everyone, and thank you for being here. I'm truly honored to be part of this international conference, and I'm grateful to the organizers for giving me the chance to share our clinical work with you today. Today, I'd like to share a clinical technique that combines preterm isolation, SDI, with polytetrafluoroethylene, PTFE tape to enhance moisture control during adhesive procedures. This approach is particularly useful in situations where conventional rubber-dam isolation is technically difficult, such as during bridge cementation or subgingival margins are present. Yeah. Before we begin, I'd like to briefly touch on the climate in Japan. Japan has 4 distinct seasons with high humidity in the summer and very dry conditions in the winter. Working in this environment, we naturally become sensitive to change in humidity. Although its impact on bonding isn't fully proven, many of us develop a habit of paying attention to environmental conditions. The combination of SDI and PTFE tape was developed from this climate-aware perspective. With that background in mind, let's now move into the main topic. Moisture control plays a critical role in adhesive dentistry and directly influences the long-term success of restorations. Rubber-dam isolation is considered the gold standard as it provides a dry operative period and minimizes the risk of contamination. However, in certain clinical situations, such as cases involving multiple abutments or deep subgingival preparations, achieving complete isolation can be extremely challenging. Contamination from saliva, blood, and gingival clavicular fluid can significantly compromise adhesion. This is why alternative strategies have been explored, one of which is a combination of SDI with PTFE tape. To better understand this technique, let's briefly review the 2 main types of isolation. First, absolute isolation, typically achieved using a rubber dam, provides control over humidity, saliva, blood, and clavicular fluid. It also helps reduce aerosol generation and the risk of ingestion or aspiration. One of the key factors that determine the effectiveness of rubber dam isolation is the adaptation between the seat and the abutment teeth. While the seat is punched in a circular shape, the anatomy of the abutment is rarely perfectly round, and the heights of the buccal and lingual margin are often differ. Because of this, achieving complete adaptation with the rubber dam seat alone is often technically difficult. To enhance the seal, additional aids such as clamps, cloths, or PTF tape are frequently required. This led us to relative isolation, which includes cotton rolls, saliva ejectors, high-speed suction, and SDI. These techniques are easy to apply than absolute isolation and can effectively reduce intraoral humidity by controlling saliva and clavicular fluid. However, they do not create a complete barrier between the treatment field and the rest of the oral cavity. As a result, contamination from saliva, blood, or clavicular fluid can still occur. The effectiveness of relative isolation varies depending on the method, but it generally does not match the level of control offered by absolute isolation. Therefore, relative isolation is considered a practical alternative when absolute isolation cannot be achieved. Among these methods, SDI has gained popularity due to its favorable balance between moisture control and clinical simplicity. It does not require any special equipment, only the same tools already used for lab isolation, making it highly accessible in daily practice. Its wide applicability across various clinical scenarios make it one of the most practical isolation techniques available. That said, its effectiveness depends heavily on the specific environment created in each case, and its clinical efficacy has yet to be fully validated through all the scientific evidence. Here are some clinical situations where absolute isolation is not suitable. The first is bridge cementation or some similar restorations. In these cases, labradam isolation labradam seat must be fixed across multiple teeth, and clamp may be located along the insertion path of the restoration. Additionally, the tension of thickness of the seat can interfere with accurate seating. During placement, the seat may also generate force in the opposite direction of insertion, increase the likelihood of critical errors. If only a few teeth are prepared, absolute isolation may still be technically possible, but this often requires multiple clamps, which increase the risk of interference with restoration. Moreover, the dam seat may become trapped between the restoration and the gingiva, which can negatively affect marginal adaptation and fit. Next, there are cases where the fixation point for the seat is unclear or cannot be secured. For example, when using vertical preparations or biological-oriented preparation technique, BOPT, and there may not be a clearly defined location to fix the seat, making it difficult to see the restoration properly. Definish lines the condition of the periodontal tissue, and even the tooth type can all contribute to the difficulty or impossibility of dam fixation. In recent years, PTFE tape has been reported as an isolation material, especially when rubber dam isolation is difficult. Dr. Shu introduced the Teflon tape technique in 2019 for thin veneers, and Dr. Roy Banakroka applied in 2022 for clamp preparation. In both cases, PTFE was packed into the sulcus to manage clavicular fluid. However, PTFE alone does not control intraoral humidity, so it remains a relative isolation method. To help deeper understanding of this technique, I'd like to explain some important clinical consideration when using PTFE tape. A 2.3 mm hole is punched, and the tape is gently packed into the sulcus with a cord packer. It can be secured using either a retraction cord or a thinly rolled PTFE strip, providing a seal and slight tissue retraction. One critical point is avoiding PTFE entrapment during cementation. During trying, we check no tape extends into the margin or path of the insertion. Before cementation, we confirm it isn't touching the integral or axial walls. If necessary, adjustments are made. Setting pressure is applied carefully, and after tacking cure, the PTFE and cord are removed. Final margins are checked for excess cement. Based on these findings, we explored combining PTFE with SDI to create an operative field that closely resembles absolute isolation. SDI is mainly used to reduce intraoral humidity, while PTFE targets clavicular fluid control. Although both techniques are considered relative isolation, they address distinct types of moisture contamination. This synergy brings us closer to ideal moisture control seen with rubber dam techniques. The following cases demonstrate how this combined approach was applied in clinical situations where rubber dam placement was not feasible. PTFE tape and SDI are effectiveness even in complex bridge restoration, both in anterior and posterior regions. In the anterior region, SDI allows us to anchor the seat in posterior teeth, leaving the abutment area free from clamps or froth. This allows for smooth processes insertion while safeguarding the aesthetic appearance. In the posterior, although anatomic limitations exist, combining PTFE with SDI still makes isolation possible. Using special clamp like the SG clamp help us secure space. With additional use of silicone putty, we can also control ambient humidity from exhaled breath, keeping the operative field dry from start to finish. After applying the SDI, a measurable decrease in relative humidity was observed. This reduction continued even after PTFE and SDI-based isolation was completed. Although nasal airflow still contributes some moisture to the field, the environment is clearly different from the typical intraoral conditions. Compared to the natural oral cavity, the operative field remains drier throughout the entire procedure. Notably, both relative humidity and temperature shows the same downward trend, confirming the establishment of the isolated environment distinct from that of the oral cavities. Unlike rubber dam isolation, cementation under PTFE and SDI isolation allows for multiple restorations to be sealed simultaneously, which increases clinical efficiency. Although long-term follow-up is still needed, no major complications have been observed in the seed short term, and the patient is satisfied with the I'd like to present a case involving a deep margin, such as vertical preparations or BOPT. In vertical prep cases, clamp or floss fixation is technically very difficult. Especially in BOPD, the finish line is intentionally undefined, which makes it difficult to identify a clear fixation point for dam seating. As a result, achieving moisture control with a rubber dam during cementation becomes extremely difficult. In such situation, the PTFE placement technique differs from that used in horizontal preparation. After punching the PTFE seat in a similar fashion to a rubber dam, the insertion method varies depending on the preparation design. A horizontal preparation in the horizontal preparation, the PTFE is pressed to follow the finish line. But in BOPD, The PTFE is inserted from the bottom of the sulcus up to the inner epithelial margin and expanded using a retraction cord to widen the sulcus. The retraction cord is removed just before cementation to allow space for insertion. The key point here is to make sure that no PTFE tape is left on the root surface. Cleaning is performed while the retraction cord remains in place. This prevents sandblasting particles from entering the sulcus and minimizes the risk of damaging the PTFE tape. If blood or gingival fluid contaminates the area, a universal cleaner is used to decontaminate the abutment surface prior to cementation. In our experiment, we assess the extent of PTFE tape damage caused by sandblasting. We observed that when the pressure exceeded 2 bar or application time was longer than 10 seconds, the PTFE shows significant surface damage. Such damage could compromise the seal and allow contamination of the operative field. Therefore, in clinical settings, it's important to keep the pressure under 2 bar, limit the exposure time, and avoid directly aiming the sandblaster at the PTFE. Cementation was performed 2 teeth at a time to maintain optimal moisture control and ensure accurate processes seating. The photos show the gingival condition immediately after cementation. The soft tissue remains stable and undisturbed. This is 3 days postoperative view. There were no signs of inflammation. The soft tissue remains healthy and the patient reported no discomfort. The area has remained clinically stable since cementation. Based on both previous reports and our clinical experience, I'd like to summarize specific indications where the combination of PTFE and SDI proves particularly effective. We have identified 5 key clinical scenarios. First, when the tooth geometry presents a challenge, such as deep subgingival margins, rotated teeth, or poor labradam sealing. In these cases, traditional labradam isolation is often unreliable or unstable. Second, in bridge restorations, where multiple abutments and complex insertion paths makes it fixation technically difficult. PTFE and SDI allows for effective isolation without interfering with prosthesis delivery. Third, in vertical preparation or BOPD case, where the finish line is undefined and clamps are nearly impossible to place. The use of PTFE and retraction cord provides a reliable method for circular management. Fourth, when treating patients with thin gingival biotypes or previous grafted tissue, where clamp pressure may result in permanent soft tissue trauma. PTFE based on isolation avoids direct pressure and is safer in these delicate cases. Fifth, during the cementation of thin veneers, where even slight tension from the dam seat or clamp could cause fracture or misfit. SDI and PTFE tape isolation create a tension-free control environment, ideal for such high aesthetic procedures. In each of these situations, this approach provides better moisture control and reduces the risk associated with conventional rubber dam techniques. Sorry. The combination of SDI and PTFE tape provide a practical alternative when rubber dam isolation is not feasible. PTFE helps seal the sulcus and control clavicular fluid, while SDI enhances environmental stability, approaching the effectiveness of absolute isolation. However, clinical success depends heavily on the accurate placement of PTFE. Inadequate adaptation can compromise processes fit or bonding integrity. While this method reduces intraoral humidity, its clinical relevance in terms of long-term bond durability remains unclear. Further research is needed to clarify its full impact on adhesion longevity. In conclusion, this technique is valuable in selected cases, but success depends on careful case selection based on anatomical and procedural complexity. Thank you for your listening. I'd happy to continue discuss here. Thank you.
Thank you, Dr. Takeshi. I think it was very, very informative about using this technique. I've always felt that isolation, like you told, especially when it comes to veneers or laminates, everything, it is a very big challenge, right? And especially in patients with hypersalivation, there are conditions, or with large tongue, or you're having anatomical problems as well. It will be difficult to isolate. So you're telling that it is more advantageous if you're using the combination, the split dam along with the PTFE tape. What about if you're using, are there indications where you would go just for the PTFE, just the PTFE without the dam? Would you consider for single tooth any kind? Will it work?
Sorry.
Am I audible?
So my audio doesn't work very well. Sorry.
Oh, okay. Am I audible now?
Yes. So, okay.
Yeah. Hello.
Okay.
Am I audible now?
Yeah.
Yeah.
Okay.
So I was asking whether now you talked about the combination, right? With the split dam, we were using the PTFE dam for the extra isolation, the moisture control that you'll get. Any conditions or any time can we use just the PTFE tape without the dam? Would you recommend it for any single tooth application? Is it possible to isolate?
What is what? Sorry.
Pardon? Or just using the PTFE tape without the split dam. Would you recommend it for single tooth in any case, any clinical case?
Yeah. I recommend if single teeth is yeah, single teeth, I recommend rubber dam isolation. But
Okay, rubber dam.
yeah, rubber dam isolation. But in some clinical situation, like deep preparation, like especially deep preparation,
Okay.
it is difficult to secure a dam seed. So in that case, I recommend PTFE isolation with split dam technique.
Okay. What about you told about that in the deep preparation, right? Sometimes PTFE can come in contact with the root surface. Is there any problem with that? You told that you should be careful that it does not come.
Yeah. In my experience, I think it's very simple. So set PTFE and insert so code. So, and I checked root surface remains PTFE. It's very simple. So, yeah, I asked, so many dentists ask me, it's very time consuming, but I think very simple. And so, yeah, so it's very easy. I think it's very easy technique.
Anyway, the presentation is open for any discussion and any questions. Please do ask Dr. Takeshi. Do we have any doubts or questions? I assume it's clear for everyone. And once again, thank you, Dr. Takeshi. It was a very insightful presentation and something good to, I think, very, very informative for the clinicians to follow. A new kind of addition towards the split dam technique. Thank you so much. Thank
you very
you for
much.
being a part of this conference. Thank you.
Thank you.
Next, we have a poster presentation. So I would like to invite Ms. Claudia Andrea Arias. She's a certified dental hygienist in Florida, originally trained in the US. Her work bridges international dental practice and oral healthcare. Her poster is titled Foreign Trained Dentist from Colombia and Certified Dental Hygienist. So, once again, please join me in recognizing Ms. Claudia Andrea Arias. Good morning, Ms. Claudia.
Hello, can you hear me now?
Yes, you're audible, Ms. Claudia.
Okay,
Your
sounds good.
video is yet to come, I think. But you can, if you're comfortable, you can start your presentation.
Can you see my screen now?
Yes, now it's visible.
Okay, perfect.
Yes, Doc. Yes, miss. Yes. You can start your presentation. Thank you.
Okay, perfect. Okay, good morning. My name is Claudia Andrea Arias. I'm from Colombia. I'm living right now in Boston, Massachusetts, and I have my license in Florida as a dental hygienist, and I'm working here as a limited dental license. The title of my poster is Strategies for Management Patient Anxiety in Dental Settings. The goal for this presentation is creating a safe and supportive dental experience. The definition that we can express anxiety is characterized as an uncertain, unpleasant, and when the patient don't feel comfortable for doing something. Also, a study demonstrate that 60% of the individuals are nervous of dental treatment, with a smaller but still significant number of adults, around 2.4 and 3.7. Also, this is a serious condition that also influences patient physical health. This is another study that said that approximately 30% of the population experience dental anxiety, with 12% having extreme fear. It is common issue that the patient avoid going to the dental appointments, also cancel last minute. The patient doesn't feel comfortable, and we need to build that relationship. This one here. Okay. This is the three main ideas that we need to pay attention as providers, like building patient trust. As my colleague said, we need to understand what is the patient feeling, like if he has any problem when he was a child, if he had a bad experience before. For that reason, I think that first of all is empathy. Empathy is related to listening. If you listen your patient, if you understand what they want, what they need, and what is the problem that we can help them, it's gonna be a really good relation between you as a provider and with your patient. All the time, we need to be actively listen to the patient's concern and validate their feelings, showing that we understand, and we try to show empathy to them. The second one is transparent communication. Sometimes we try to explain with a terminology that just dentists understand or even another providers understand, but no patients. We need to understand that all our patients doesn't have the same level of education. We need to understand that patients are afraid to demonstrate, to show you what is the main concern, and the patient don't just want to say like, yes, I understand. We need to go back and forth to show them empathy, explain the procedures in detail, like I'm gonna put, this is your first dental cleaning, this is your first dental visit in your life. Do you have any experience? And also the other one is building reports. Take the time to get to know the patient. As I said, we don't know the patient, we don't know the education, we don't know what happened before the patient came to our dental chair. And for this reason, it's very important to have like that communication. That way, the patient feel comfortable and he can have like a really good experience in your dental office. And the examples that I want to show you, like understanding the cause of the dental anxiety. First of all, we need to understand the past traumatic experience, if it's the first time or if the patient had like any bad condition before, if was painful or if was unpleasant dental procedure that developed a fear of returning to the dentist. Like the second one is lack of control. Patient may feel like a powerless, and sometimes they cannot express themselves pretty well, and we need to try to guide them to understand what happened. Try to speak slow, calm, and relax. That way we can have that engagement with the patient. The third one is dental phobias. Some individuals have irritational for example, for the sound, like it's pretty loud, the suction, the anesthesia. um, and here I want to show you like the consequence of dental anxiety. As I said initially, this one is a this is a psychology problem, and we need to understand how is everything with the patient. First of all, is a physiological disruption. That's mean like the patient can have dry mouth, the patient can be sweating, increase heart rate, and at that time we can start pay attention how the patient feel. If we need to stop, we can stop and try to understand what is the reason that he active like that. Also, this one is going to affect health change. Sometimes we have patients that said, "Oh, I didn't sleep before because I was thinking all day about my appointment. I don't know if it's gonna hurt or not." Um, Sometimes they have poor oral health, and they sometimes they said, "Oh, I floss," but they don't know the technique. I think that the most important thing is that you show the patient, and the patient show you what he'll learn. The third one is disruption of social roles. Um, some of our patients, I especially speaking because I'm working in a community health center with a underserved population. Sometimes they don't feel comfortable smiling because we don't know what's going on before, like if they have family problems or about the economic situation. We need to understand, and we need to try to help them, to guide them, to give it like a referral to go to another place, to have like the social interaction active again. The, the next one is like the patient have cognitive change, like sometimes they are like in depression, they taking medications, they say like in their family they don't listen to them. We need to understand what is the background, like the patient taking medications, what's going on before the patient sit in our dental chair. And this is the other one, behavioral change. This one here. We need to try to create a really good environment. We try to use soft and indirect lighting to create more calming and invited atmosphere. Also, the colors are very important. Like we most of the time we use like a sky blue, greens, or something like a very relaxed for the patient. The decoration that we use in the dental office is like something comfortable. We try to put like everything as the patient feel like is at home, and for the noisy, we try to minimize distraction, and we try to hear the patient, and the patient hear us what we try to say. This is the three related but different concepts. We have dental phobia, dental fear, and dental anxiety. We can describe dental phobia as a person with a dental prefer like a stop the treatment, stop the appointments, only choose the visit to the dentist in extreme circumstances. That's mean that this is the kind of patient that just show up when they have like an emergency situation. For example, they have a really bad pain, or maybe the tooth is fractured, and they just come that day and disappear. The next one is that dental fear is typical involve prior knowledge of the dentist, and this one is like a occurring when the patient feel like a distress or no feeling like a really comfortable. The dental anxiety is an individual who has never had dental checkup before and may experience dental anxiety feelings to a new activity that we are going to do. For this reason, we need to explain the patient everything with details. We need to explain like we are gonna put the mirror in their mouth. We're gonna check the teeth. We are gonna show you the X-rays, what's going on in their mouth. Another one is etiological factors of dental anxiety. Most of the time, women and girls are higher than compared to boys. Also, the study said that the age more frequently in young adults than older people. That means like around the age 15 to 25 is when the patient have more anxiety or dental fear. Um, education, education, more common individuals with lower education and those who are single. Physiological is related to general anxiety, personality traits, and psychological status. The cognitive is a lower anxiety in children with a higher verbal intelligence. And the environment is post-trauma and negative dental experience. This one These ones are some distraction methods that we can reduce the anxiety. Most of the time, we put in the dental office music therapy. That means that we're gonna try to put like a relaxed music, a visual distraction. We can put like a TV and give the control for the patient to find like something that they really want to see and try to distract uh, their mind. A friendly conversation. Imagine that you are the person that is sitting in the dental chair and we are gonna put the anesthesia. Doesn't gonna feel really comfortable. For that way, we try to explain them like you need to be strong, like that is gonna be super quick. Don't and the breathing exercises. I think that this one is so important because sometimes we have patients that they stop breathing and hold the breath just because they are afraid of what's going on in the next step. For this reason, all the dental appointment, I think that is so important to communicate with your patient to see how the patient feel if he move their leg, if they move the arm. All the time say the patient like a specific keys, like if you feel pain, just raise your left hand and we are gonna stop right away. And these one are the three options that as a dentist we can use, like a nitros, oral sedations, and IV sedations. For nitros is inhaled sedative gas that help patient feel more relaxed and less aware of the procedure. Here in United States, we need to have license for all of these ones. And also we need to be very careful what kind of patient we are going to provide this kind of sedations options. Oral sedated is prescription medications that the patient have to take before the appointment. That way, it's gonna help the patient feel drowsy and less anxious. And IV sedation is an administration of sedative medication directly into the bloodstream. This is three options that we can use in the dental office. And that be all set for today. Thank you so much for your attention. And if you have any question, please let me know. I'm very happy to answer.
Thank you, Miss Claudia. I think it was a very, very informative presentation and very, very applicable to what is happening over here in the dental situations, right? Anxiety is always, I don't think it is the patient's problem. It is a huge problem for us as clinicians, right? To face or deal with patients with anxiety. So thank you so much. And I would like to open the presentation for any for discussion as well as any questions, queries.
Hello.
Hello. Yeah,
Um,
please ask your question.
Yeah, hi, Dr. Claudia. Thank you for your nice presentation. I'm Dr. Sana Faak. Really, anxiety is a very important issue to be tackled, especially when it happened for the first time. For a patient came to your clinic for the first time. You don't know who or she is, and the patient is coming for the new dentist for the first time. It's very important. And it's very important to deal with it before dealing with the dental problem, because that anxiety, if not be handled carefully, it will transfer to fear, and that will stay with the patient for the whole life. It will be the bad experience that he will suffer for long. Sorry. Thank you. Building the robots, Dr. Claudia, is very important. Yeah.
Thank you so
Take
much.
care of your voice tone. Take care of the words. Sorry.
Yeah.
Can
Thank
you hear
you.
me? Yeah.
Yes, doctor. You can continue.
Yeah.
Okay. Okay. When you express your confidence, that will soothe your patient's anxiety. If you can add it to the methods of dealing with patient's anxiety. Thank you, Dr. Claudia. I will contact you on LinkedIn. Is it okay?
Yeah, for sure. Thank you so much.
Thank you, Dr. Sana, for your comment on the presentation. And thank you, Dr. Claudia. It was really, really helpful for all the clinicians. I hope you do really good in your practice as well, managing these patients. Thank you so much for being with us. Thank you.
Thank you so much for the invitation. I appreciate it.
Thank you. Thank you.
Thank you. Thank you.
We'll swiftly move to the next speaker. Our next speaker is Mrs. Lauren Mooney from the United States. She's the founder of Be Highly Reliable and Speaking In. Her work focuses basically on reliability in healthcare systems and workforce training. She will present on the topic Beyond Theory, Equipping Employees to Practice High Reliability Organizing. So please join me in welcoming Mrs. Lauren Mooney.
There we go. Hello, everyone, and happy middle of the night from the United States. I'm excited and to present today. So I'll go ahead. This is what I look like, but I guess you won't be seeing me for the rest of the time. I'm going to go ahead and share full screen of my slides. Okay.
Please start the
oh,
presentation.
Let me just hit share full share, and we're going to hit.
Yes, ma'am. Your presentation is visible.
Yeah, I just want to do full screen so you're not seeing these notes. There we go. Okay, is this good?
Yes, ma'am. You can start the presentation. Can't wait to hear. Thank you.
Okay, so hello, everyone, and thank you, organizers, for inviting me. My talk's called Beyond Theory, Equipping Employees to Practice High Reliability Organizing. Excuse me for having some notes to the side here, but it's very, very much in the middle of the night here. Also, excuse my night voice. This topic is exciting because I believe it is the biggest opportunity to improve organizational performance that we currently have. And it not only elevating patient safety, most importantly, but also improving the employee experience for the wonderful people who have been called to deliver care. So in terms of delivering care, I want to just, okay, here we go. I want to honor the very long legacy of care that you have in the Middle East. As I was studying and getting ready to come to speak actually with you, however, my knee had other ideas, I learned that your places for the sick were called Abaymaristan, and that now you call them Madar el-Shifa, the House of Healing. I really love those names. And just like these ancient organizations, I know that today you are working to take care of a diverse population, and you've always known that factors like risk awareness, cultures of safety, and empowering voices were important way before there were regulators. And now you also have them asking you to work on these components of your organization. And I know that you diligently are. However, if you're like any healthcare organization across the globe, there's places where you're putting in great efforts, but maybe not really moving forward. So my question for you today is, are you stuck? Are you on some kind of improvement journey, a high reliability journey, a process improvement journey, a lean journey, and you're finding that you can't move forward? And maybe you're frustrated because you found that, you know what, the compliance and the process improvement are not enough to create the level of excellence that you're looking for. Maybe you're finding that no matter what you do, unclear and unexpected events pop up. There's trouble handling them, and you're experiencing unwanted outcomes. Or maybe you're having trouble getting people to speak up. You've repeated and repeated, please speak up, yet they won't because of feelings of fear or futility. Or when they finally do, you're having trouble getting leaders to really take them seriously and take action. So here's my good news. You are perfectly normal if you have these problems. These problems are absolutely natural in large hierarchies where you're doing high risk work. So today I want to shed some light on why you're facing these challenges and share some tools and strategies to get you unstuck and moving forward. So first and foremost, it's really important if you want to achieve high reliability that you really understand and embrace the full complexity of the environment that you're working in. So one of the things I love to do is make models to help people understand. So I call this model the wonderful wild world we work in. And this is the totality, and no one can draw a picture of complexity, by the way, but this is my best shot. The totality of our work is represented by these layers. On the outside, we have our complex socio-technical system. That's what we all work in. However, airlines are complex socio-technical systems. hospitals, nuclear power plants. We all have them, and they have some very interesting challenges to them. Because we have so many plans linked together, we end up with interdependencies that we don't know exist. And what happens is we can make a change that we believe is going to be good in one place of the system and have it affect a different place in the system that we never, ever expected. Another problem in complex socio-technical systems is that things are constantly changing. We have a dynamic work environment. Therefore, we need to continually monitor and scan our environment for risk that, as we say, emerges. Third, this naturally creates unclear and unexpected events. They're normal. So now, despite all your training, humans have to figure out in real time what is actually happening and what they're going to do. The most interesting part for me about a complex socio-technical system is that no one person actually knows what's happening. It's a complete and total collective of minds and actions. So this naturally creates what I call the dark space. And this is shades of gray or black that's always around us where things are happening that we can't see. But some of them need to be seen or will pop into the light unexpectedly. So that's our outer layer of complex systems. Our next layer is people, and I put them separate because I believe they deserve, even though they're part of a complex system, they deserve their own space. And they are humans, all we don't have different sizes, but shapes, colors, different backgrounds, experiences. We are all very, very different. And we come together to actually create and run these complex systems. So the thing we want to remember about our people when they come to work is that on one hand, the first thing we want to focus on is that they're fabulous. And instead of starting with to err is human or people make mistakes, we start with they come to work to do a good job, and mostly all day, they're actually adapting to gaps in the systems. On the other hand, we have to recognize then, of course, that humans can fail, and we need to be ready to support them with a system that can tolerate error. And finally, humans have free will, and we always have to factor that into our risk management. In the middle, our Earth, our wonderful Earth, is known to be VUCA. If you're not familiar with this term, this is something we use extensively in the safety field. It came out of the Navy War, the Army War College. It basically talks about our Earth being volatile, uncertain, complex, and ambiguous. This basically means that we are working in a place, in a world that is not stable, unpredictable, it's not simple, and it's not clear. And we are dealing with politics, regulators, financial markets, and even quite a huge factor in disasters is weather, as I've studied many. So ultimately, we don't end up in a tame, controllable workplace, but something wonderful and actually quite wild, creating unexpected events for us and unclear events all day long. The problem is a lack of capacity to recognize and respond to unclear and unexpected events completely cripples your ability to achieve operational excellence. But here is the good news. You can actually seamlessly layer what I call a complexity conscious operating system into your work and equip your people to recognize and respond to the challenges of complexity. So the other thing you can do, and something that differentiates my work, is improve your relationship with complexity. If you've read it all about organizational complexity or theory, sometimes it's presented as an enemy to battle, or that it presents wicked problems to tackle. My position is that instead we should think of complexity as a powerful horse, something much stronger than us and able to take us to places we could never go on our own, but also with a very specific nature. And we need to learn to work with the nature of these elements or this horse in order to go where we want to go. So I suggest that instead of conquering or battling complexity, we actually befriend it. So I am, in fact, Lauren Mooney. I'm a nurse, an entrepreneur, and innovator. And what has happened is my personal and professional life provided me with the time compression of many unexpected events. I totaled it up, and I've actually walked through over 7,000 complex situations where I had to make decisions with imperfect information. And I also experienced in my life 3 family members with life-threatening, difficult diagnoses, some of them which spanned years. During this time, I became so interested in how we think and act in uncertainty and unexpected events that I decided to make a career out of it. So now I'm on a mission to enable and equip people in high-risk work with high-risk with the tools and the strategies that allow them to thrive in our jungle of uncertainty. So I'm here today to tell you that high reliability organizing and that operational excellence is not out of reach. I'm going to share frameworks with you that you can take and get started with today. I'm going to be always available to facilitate HRO in the future should you need it. What I'm not here to do is fix you, because you are not broken and you are absolutely there's nothing wrong with you and you are perfectly normal. So in the next few precious moments, we are going to tackle our mission, not impossible. My goal is to get you excited about HRO, high reliability organizing. I'm going to show you 2 maps, one of which I already did, to help you understand why you need high reliability organizing. I'll share those 3 application frameworks to enable you. I'll share 1 huge communication shift I call speaking in. And in the end, I'm going to send you on your way with 3 simple steps that you can start today to apply this powerful, proven technique, no matter what your industry. Whether you are a dentist, I enjoyed your presentation. My husband, in fact, is a dentist, so everything you were saying was very, very relevant. So, I am sure that you, no matter where you work, sometimes even in our own lives, we are saying we want things to be different. And we are spending time and effort and money. And matter of fact, we started in 2000 with a call to action in the United States to transform our healthcare organizations to places that are safer for patients and for staff. However, it hasn't gone so well, and we have struggled and struggled. So my question is why? And I would say that Dr. Wiley Suba of Dartmouth gives us the answer. He says most healthcare transformation efforts are unsuccessful because they overlook the importance of personal transformation in enabling that major systemic change. Because truly, if we are going to change a system, what is the agent of changing the system? It is, in fact, the people. So, okay, if we want personal transformation, what exactly does he mean? In what ways do I need to be transformed? Well, he informs us that personal transformation is about creating access to a broader range of ways of being, thinking, and acting in order to be more effective in dealing with those challenges for which our conventional strategies are inadequate. We know the data from patient harm, we know the data of employee burnout, and we know that our strategies for those serious problems are not yet adequate. Okay, so being, thinking, and acting. Could it be that operational excellence is actually achieved through changes in these areas? Well, I'm here to tell you that the research and history tells us yes, that there is actually a lived practice. HRO is a lived practice, which means we're going to live it in our being and our thinking and our acting. And here I have some resources for you to dive deeper. One, this is some of the, on the left, original research out of Berkeley on the self-designing high reliability organization, where they studied the aircraft carrier. I have no idea why my slides are doing that, and I am sorry. And that QR code will take you right to the article, and I suggest you read it. It's fascinating. Also on the right, I have the book that changed my life, written in 2001. The messages are timeless. And as I said, no matter what your industry, you'll find that it brings incredible strategies to deal with complexity. Much of my work, is a derivative of the works that of Dr. Wyke and Sutcliffe in their 3 series here. So I'm going to tell you the bottom line of high reliability organizing that you would come across if you read the book, and what causes us to struggle day by day. The point is, you cannot write procedures to anticipate all the situations and conditions that shape people's work. In fact, I used to find myself saying, I wish I had a t-shirt that said, "This cannot be happening." But the truth is, yes, it can. We are actually unable to plan for in advance all of the types of events and variations that we will find in patients, in coworkers, in situations unfolding us around us. We will and have to enable our people to act in ways consistent with HRO, and we're going to have to, as leaders, and we're going to have to equip them with the strategies. Okay, but what are those strategies? And this is where a lot of people get hung up. What are those HRO folks actually doing to create that consistent success out there on those nuclear carriers? Well, the big surprise that I had it's actually this. We attribute, and you can see the quotes here, these are quotes from the book. We attribute the success of HROs in their managing the unexpected to their determined effort to act mindfully. By this, we mean they organize themselves in such a way that they're better able to notice the unexpected in the making and halt its development. Oh, mindfulness. Okay, we're getting closer, but I don't think that's enough. What does mindfulness even mean? And is this mindfulness where I might close my eyes and put on a candle and meditate? No, quite the opposite. This is actually something called Western mindfulness of Dr. Ellen Langer of Harvard. And what it means is that instead of shutting down, we are actually very much engaging in our environment. So the mindfulness that's creating the proactive and real-time risk management and awareness in high reliability organizations are these 4 practices. 1, embracing uncertainty. I'll tell you that as humans, we don't like it. We will tend to avoid it, ignore it, and write it off as something very simple. Oh, it's probably just she's tired. You smell smoke, it's probably just the neighbor's barbecue. We have lots of ways of not moving towards uncertainty and embracing it, but yet pushing it away. Next mindfulness practice is awareness and analysis of automatic behavior. Our brains want to conserve energy, and we tend to go on autopilot. Autopilot and high-risk work are incompatible. Third, there's the practice of rethinking categories. This means constantly updating what we are labeling in our mind. As situations emerge, we'll engage in a process called sense making, meaning we just make sense of what's going on and then we label it. Well, what we found is that many times the catastrophe happened not because someone made a mistake, but because as a group we mislabeled what was going on. And if the 4th practice I want to highlight is welcoming new information versus pushing new information away, and maintaining a kind of open mindfulness as to what is going on. So I ask, how much attention do you pay to these practices in your workplace? Have you equipped your employees for any of these practices? Have you put systems in place to make them commonplace? The good news is you can. And these practices, what I've done is taken them and embedded them into 3 high reliability application frameworks that you can use. And I'll be giving you a QR code to all of these as we go through them. So these are the 3 frameworks that I've distilled to support organizations on their high reliability journey. First is a compilation of 7 amazing attitudes, and we'll go over each of these separately because really high reliability, it does not spring from your policy and procedures. It springs from the attitudes that we bring to work every day. I have 7 of them, and they're each represented by an animal. Second, there's 9 high reliability mindset questions that we can always be asking as we work. And third, I created 9 high reliability action prompts. These are actions that you can trust to put you on a good path and a safer path when you're working in complexity. Okay, so we're going to start with the action prompt. So there's 9, and we certainly don't have enough time to go over these today, but I will show you at the end that they have come out in a new book that I just published in June. So today, because I'm going to be sending you away with your HRO Quick Start, we're going to just focus on 2 of these. The first one is acknowledge the presence of unknowns. Create condition for real-time learning. And as I said, if you scan the code, you'll be taken to a Google Doc where you can actually download and print this. It will come up as an 8x5 little poster for you. So, okay, acknowledge the presence of unknowns. Well, it's easy to give lip service to that. Okay, I acknowledge the presence of unknowns. That's the easy part. The hard part is having this acknowledgement permeate everything you do, your thinking, your mindset, your communication, your planning, your actions, everything from how you staff to how you create an environment. We have to be aware that there are always unknowns as we work. If you did not know, there's actually a whole field of study called resilience engineering, which is dedicated to helping design organizations that are prepared for unexpected events, or as they lovingly call it, surprise. So we have to really acknowledge that presence of unknowns. Well, if we have unknowns that need to be known, we're going to have to work on the second part of this sentence, which is create conditions for real-time learning. Real-time learning is what allows us to recognize and respond to small signals of potential trouble before they actually become real big trouble. I was excited to hear Mr. Abdallah Anora speak on, I believe, day 1 about his rapid response team and his golden rule, which was identify, mitigate, escalate, and do it all sooner. We need to learn in real time fast. This golden rule he presented is completely in line with high reliability organizing. So I want to talk about real-time learning now in organizations and just say that right now we have a real big globally elephant in the room, and that is employee silence and a fear of speaking up. And it is absolutely impossible to learn in real time when we have people who are afraid to speak up. And I'm going to address that issue with a solution later. So, however, I don't want you to feel entirely at loss because there's this big dark space at the bottom of our iceberg where that represents the more is actually going on in your organization than you know, and it's actually the bigger piece. I want you to know that we can map this out. So I made a map of this in 2015. In 2015, I became a legal nurse consultant, and after that, I created a database of 353 cases of the very worst harm that had happened over 35 years in the United States. And as I created that database, I found a pattern of what was actually creating the real big harm for patients. And I collected these dynamics, found them to be natural challenges of complexity in all organizations, and I call them the UNs. And basically, if you've done any incident review, see how these resonate with you. Mostly what I found when we had a bad outcome is that something just went unseen. If people had seen it, my goodness, of course they would have addressed the situation. Secondly, I saw that something was seen, but it was unclear as to what it was. It was what we call ambiguous. They mistook their world, and that's what actually caused the harm. Third, I saw things that were unstable. This means that things showed up in a way that was bigger or smaller or faster or slower than the system was prepared to handle. We call that variability in complexity. Fourth, things were happening, but they went unspoken. Maybe they were spoken, but they fell on deaf ears. They went unheard. I also saw many, many times, and we see this in risk management, we did have the right idea finally of what to do, but it was too late. Things were untimely, and that's that do it fast. Oh, I am so sorry about that. Unfortunately, we found that some people were unable to respect the basic human rights of others, and there were events that happened because people were uncaring. And then extremely common, the good old unimagined, and it is unimaginably, I believe, misspelled there. These are the uns, though, that are going to challenge you in complexity. And I'm going to share with you now one of the ways you can start addressing and befriending these challenges of complexity. And that is with your attitude. There's 7 attitudes. I have a little exercise where I say, okay, this is our attitude zoo. These are the attitudes that create high performance. And is there any one animal that we can kick out of our zoo? And no matter how many times I go over it, I find that they're all extremely important. I have humility in the center because it positions us to learn, and people in high reliability organizations at their core are always thinking about positioning themselves to see as much as possible. However, in addition to humility, we will need courage, respect, vigilance, appreciation, open-mindedness, and a continual curiosity. So let's dive a little deeper into the one attitude that you'll have as your takeaway, and that is humility. There's 2 types of humility that will fuel your high reliability organizing journey. The first of those is an intellectual humility, acknowledging that my beliefs and opinions might be flawed or incomplete. I have to stay open to debate, and I need to change my mind based on new evidence. Secondly, we have to think about situational humility. Okay, this is about us in reflection with the situation around us, and we have to recognize that in some situations, others have more specific expertise, more experience, or a more insightful perspective because they're closer to the situation. This is represented by being willing to be open to learn from others and welcoming that new information. There's one more action I want to share for you to use on your takeaway journey, and that's number 4. That's choosing complexity conscious conversations. That's when we, in our communicating with others, stay curious, we resist quick answers, and we're always including other perspectives. And I'm going to show you a model that I developed after studying HRO and, in addition, the problem of employee silence. And this is why I advocate that you might consider what I call a science-based switch. We know from the data and the stories that telling people to speak up does not work. There's many, many reasons. The basic one is that it doesn't align with the nature of human beings. It also doesn't align with how complex systems function. But the hugest flaw, 2 huge flaws, is that 1, repeating this phrase, speak up, does nothing to overcome the factors that are driving the silence. So we are just stuck in spending time and money on something that doesn't work. And more importantly, telling employees to speak up is an employee-based solution for what is actually a leadership issue. So I actually innovated a model called Speaking In. You can devise any model you like. The research is out there that helps us understand that we need to change the way that we communicate as leaders. What that means is that speaking in means when we are the person in power in the room, we understand that it is our responsibility to intentionally meaning bring the people to the table, invite, and then appreciate diverse perspectives. So the complexity conscious conversation as a leader or the person in power, which sometimes is the nurse in the room, can even be the valet parker of your cars. If he is helping an elderly couple in, he's the person or she, the person in power in that situation. Is 1, ask fear-reducing invitational questions instead of waiting for people to speak up. And 2, when they do share, making sure that you appreciate the gift of the knowledge that they just shared with you. Because if we do not appreciate what is shared, I can tell you that your flow of gifts of knowledge around you will dry up. We are already working in uncertainty. The last thing that we need is people being uncertain if it's safe to share their perspective. Okay, so that is a little touch on what a complexity conscious conversation might look like, and you can always check out my website called speakingin.org. Now we're going to go to, well, okay, we're asking fear-reducing questions. I just want to back up. I forgot a little note there. What's happening in this slide is the fear-reducing question means when I ask the question, I add what's called a sentence starter. And we'll touch again on it later, where I make a promise and I say, I'd appreciate hearing, and then we add the question, okay? So I am signaling in advance that I am going to appreciate what you share, and then by golly, we sure have to make sure we follow through on our promise. Okay, so now here is a distillation of questions. This was my first framework, and these questions are almost like training wheels for high reliability organizing. And I will tell you that I divided them into 4 sections: questions that help us anticipate and notice emerging events, questions that help us probe what is unclear, questions that help us adapt and contain a situation, and question that helps us learn and improve. You will go really far with just asking the questions, what's the intention here, so that we can make sure everyone's on the same page. And 2, the very powerful question, what must go right? These will make sure that your critical factors are performed successfully so you can experience the outcome you're looking for. However, for our purposes today, I'm going to highlight question 5, the most powerful HRO question. This question does some amazing things. But before I go into that, I want to talk about this whole shift from becoming a shift to a complexity conscious conversation where instead of being telling leaders, we become asking leaders, because a question does more than ask a question. A question is more than a tool for gathering facts. It's actually an act of leadership. And it's this big lever that you can pull for learning in your organization. And here's what it does. It shifts our focus to what's been overlooked. It can surface hidden assumptions in the group that we did not know were there. It invites those quieter voices to the conversation. It disrupts the autopilot that lulls us to sleep as we're working, and it sparks curiosity. It says we're not done learning yet. So I just want to encourage you to lead with questions and experience their power. So here you are. Asking the question, leading with that sentence starter. I would appreciate hearing what's surprising you. Now, the question, what's surprising you, is so powerful because what it does is it illuminates the gap between what we expected to happen, what was in our plans, what we've seen every time before, and what's actually happening. Now, lots of times, our human nature, we will notice something, but we will not bring it up for a variety of reasons. A lot of times we just think we're playing crazy. I can't be seeing that. When we go ahead and make it clear that it's okay to talk about surprise, you will be amazed what the perspectives in the room will bring. So here is your action plan. I'm actually going to skip this slide and just take you to your last one. So I call this your HRO 1 week quick start. There's your QR code. I tried to replace it. This has no, somehow my logo got left off the bottom and there's no attribution, but my business philosophy is hand out the information, hope it changes the world, and if people need help, they'll come to me. So here, you can go ahead and print this, and I challenge you to do this. And please, if you do it, connect with me on LinkedIn and let me know the results, because I'm 1,000% confident that you are going to be learning this week about your system and about your people. So this upcoming week, I challenge you to do this. Acknowledge the presence of unknowns in your communication, in your emails, in the space you leave for others to share perspectives in meetings. As you walk into a room, don't be overconfident. Realize there's always more to learn. Practice that amazing attitude of humility. Ask yourself, how can I demonstrate more humility and more respect for others' perspectives as I work? And then simply choose this complexity conscious conversation where 3 times a day, in wherever you are, it can be in any type of meeting, and it doesn't have to be a clinical setting. It could even be, let's say you're working on a project together. Now you're 4 months into this project, and you say, well, you know, we've set out to do this. We've had 4 meetings. And my question is, as we're moving in this project, what's surprising you? And you'll find out that almost nothing goes as we expected. And those surprises represent not only just a threat, but many times opportunities. So as you endeavor to work in your increasingly complex organizations, as you are tackling the unexpected, I just encourage you and call you to create a future where people are competent and comfortable in complexity. So please download, print, and use the frameworks. Consider a 10-week application adventure. That's actually what I have in my book, where you absolutely do a do-it-yourself high reliability journey with your team. And of course, if you're stuck in any way, call me for facilitation. I'd be happy to help you. I do use a meerkat in my logos because those amazing little creatures will crawl up into a prickly tree to position themselves to see as much as possible, scanning their environment for threats. And I ask all of us, what are we willing to do to position ourselves to see as much as possible? I'm very available. Please follow me on LinkedIn. I thank you so much for this opportunity to share. And I encourage you to explore HRO because you will find it absolutely empowering and uplifting of your employees' experience as they realize how important they actually are. Thank you again for your time, and I'll stop my share.
Thank you so much, Mrs. Lauren. I think that was something, a fresh take on, what we need to work on ourselves, right? With the day-to-day life, clinicians facing a lot of problems, we do speak. I loved your concept in a way that we do speak out. We do speak out, but sometimes we need to speak in also. Go talk to yourself, like think about what is wrong with yourself, right? I think it was amazing. It was really good, and I will check out your book as well as your website. Thank you so much for sharing. The platform is open for questions. I would request anyone, if you have any queries or questions, please do ask now. Ma'am, I do want to ask something about when you talk about reliability, right? Now, I'm a clinician, I'm having my work, and what do you mean exactly by being a reliable organizer? Being a clinician, I'm looking after my family. There's a lot of things going on. According to you, what do you mean by being self-reliable or being the reliable organizer?
Okay, sure. So high reliability really is, even though I'm introducing what an individual does, ultimately it's seen as the collective. And forgive me for not going a little more deeply into that. High reliability organizations were labeled after, in the United States, they realized there were these organizations that had very high risk work, and they should have had more failures, but they weren't failing. They're like, how are they consistently? The nuclear navy is one of our big area where there were no accidents when there should have been. So the beauty is they didn't go out to study what was going wrong. They went out to the ship and they said, what are these people doing right? And they found their 5 hallmarks, and those hallmarks are in that yellow book. Preoccupation with failure, meaning they're always thinking something could go wrong. Sensitivity to operations, which means completely different words in healthcare, but what it meant is the smallest detail that they would pay attention to, like a tiny screw on a deck. The lowest level person could stop the flights because they knew that that one screw could cause a plane to have a serious incident. Reluctance to simplify. This is a big one, and this is where we get in trouble with diagnostic error. Reluctance to simplify interpretation means these organizations don't just take for at face value the first labeling of a situation. They're always digging deeper to say, is this really what's going on? And when that slight bit of disconfirming evidence comes that maybe we don't, they welcome it. They don't say, oh, don't tell me I'm wrong. They say, we could be wrong. Let's look deeper. So they found those mindfulness patterns among everyone that worked on the ship. And so really what has to happen in an organization for you as a clinician to be you I'm sure practice all kinds of reliability, and you naturally are doing lots of these things. What can happen, actually, we do these things in our daily life better than we do them in the organizations because the bureaucracy, the time pressure, actually can strip our ability to navigate, because you've been in a situation where if you applied the rule, it wouldn't be good for this one patient. And you're like, I actually have to adapt. So you have to enable your people to say, I have to do it differently this time because we never expected this, or I'm going to improvise and glue a solution together in real time and not be in trouble. Realize that's natural work. So you need leaders who understand, we call it emergent risk, that if we do nothing but follow our plans, it will never be enough. There's always the surprise. There's always that different situation. So really it's about working together as a group to still achieve the outcome. So the process is allowed to vary. So when we talk about reducing variability, we don't want to reduce the variability in the goal, excellent care, the right diagnosis, no infection, but we might have to vary how we get there depending on the dynamics in our environment. So
Sure. I can totally understand the difficulties and how you are helping, right? You are coming out with this kind of a project in order to help this kind of what you are believing in, right? You are helping people. And thank you so much, despite of I can imagine the time over there. It's the wrong time to be asking questions and keeping you waiting. Thank you again, ma'am, for your cooperation, your wonderful speech, and I hope we all have, everyone who's listening have been enriched a lot by this. Thank you so much. Thank you for being a part of our conference. We are really glad to have you.
Oh, thank you. And as I said, please connect and reach out. Introduce the idea to your risk managers. After looking at all those cases of harm, I knew that I wanted to work in a proactive way and not looking back after the event is too late. So,
Yes,
all right.
sure.
Thank you for your wonderful work and your great conference.
Thank you. Thank you so much, ma'am. Thank you.
Bye-bye.
Thank you.
Thank you.
That was our esteemed speaker, Mrs. Lauren. And now we'll be moving on to our next speaker. Our next speaker is Mrs. Ellie Leclerc, a registered nurse educator at M Health USA. She has been dedicated to advancing nursing education and improving awareness in dementia and Alzheimer's care. So her session is titled Dementia Alzheimer's Education Workshop. And please again join me in welcoming Mrs. Ellie Leclerc. Good morning, ma'am.
I believe
Ma'am, I
she's
request
muted.
you to unmute.
I just
Um,
did.
yes, thank you. Thank you so much. You can start your presentation.
Okay, thank you. Yeah, and welcome Dubai and everyone around the world. Thank you for giving me the opportunity to present during this very important occasion. I am here to impart information that will be helpful, though it's not going to be all inclusionary at this time, and to provide you with enthusiasm and desire just to learn more. It seems my slides are not wanting to move ahead. Are you able to move it for me? Are you able to move my slides for me? Because my slide won't move ahead.
Ma'am, we'll try about it.
For some reason, it will not move ahead.
Can you try to go back to the before the slide share?
Yes. I guess I can do it this way.
Actually, our team is trying to share the, yeah.
I can just
Is
move it
it
ahead this way.
okay?
Or do you want me to go on slideshow?
Yeah, it's fine now, ma'am. You can start. Okay.
Okay. Understanding dementia, it's a global and local perspective with collaborative approach. No one person can do it alone in caring for people. These conversations need to be done amongst cultures from America to around the world. Again, I am Ellie Mary Catherine LeClaire, and I'm an RN here in the United States. The agenda for today is for me to define dementia, provide statistics, identify some risk factors, explain signs, symptoms, and behaviors, describe common types of dementias, recognize behavioral clues, review detection, testing, and diagnosis, and point out some new strategies that are out on the horizon. And then I'll summarize in closing and how to contact me. Now, this is a collaboration, not a lecture. The longest journey begins with just a single step. And today we take that step together for those living with dementia, because that's a very difficult disease for people. I'm not here to lecture, but to collaborate with you. You're the professionals, the change makers, and we together can make early detection, safer care, and better support possible for all of these people. So what is dementia? We've heard that term many times, and I'm sure everybody knows some of a definition. It's a general term for decline in mental ability severe enough to interfere with ADLs or activities of daily living. It's not a specific disease. It's an umbrella term because there are so many different dementias. It's progressive and I shouldn't even say often irreversible, but thus far it has been irreversible, although medications now are coming up to make the disease progression a little bit better and change that progression through those medications. Some global dementia statistics. These are ones we don't want to hear, but they're out there and they are real. That over 55 million people worldwide live with dementia. And that's according to WHO, the World Health Organization. And there's one new case every 3 seconds. Isn't that just astounding? And it's expected to rise to over 139 million people by the year 2050. In the United States alone, there are over 7 million people with dementia. And if we keep going this way, it's going to be 12 million by 2050 just in the United States. Some of the risk factors for dementia, some are non-modifiable, you can't change it, and others are modifiable. The non-modifiable are our age, we progress in age, obviously, our genetics, and family history. And just because you do have someone in your family that has dementia doesn't mean that you will get it for sure, but it does increase that risk. The modifiable things that we can change and we need to pay close attention to are hypertension. We've got to keep our blood pressure at our whatever is the recommendation per the CDC and World Health Organization, and it changes. Take care of our diabetes to not have our blood sugars fluctuate. No smoking, treat depression, to prevent head trauma as best that we possibly can, and that starts with young kids. Look at hearing loss, social isolation, and inactivity. These are all risk factors that we can change. Now, what are signs, symptoms, and behaviors when people have that we think might have dementia? Now, we think of memory loss as being number one, but it always isn't memory loss that brings us to identify that the person may have dementia. Although, especially short-term memory, people tend to remember things that are in the past, long ago, but they don't remember what they had for breakfast in the morning. And that is all very common. Confusion with time and place. Now, they have gone to this certain place many times before, especially if they are working and they have driven and they've gone there. And now they don't know, once they got there, how do I get home? They're confused about streets, and that might be a clue to the family as well about driving. And they're confused about time. What time is it? And they ask those questions over again. Also, they're confused about, is it morning? Is it noon? Is it night? So they don't have a time reference. They have trouble with words or conversations. And they're trying to figure out that word. What was that word? I'm trying to get, I can just feel it. It's right at the edge of my brain right now, but they can't pull it out. Also, with conversations, there are a lot of persons with dementia who don't get involved in conversation because they don't feel comfortable. They don't hold conversations very well with people because they're not remembering words to contribute to that conversation. They have difficulty with familiar tasks, things they've done many, many times before. The woman or man who has cooked for a long time, for example, and they know this recipe inside and out, but now they can't follow the steps. They can't execute what they knew by heart before. So they're things that they've done a million times and now can't. Their mood, behavior, or have personality changes. And sometimes this is actually the number one reason that people will say, well, I think Grandpa needs to maybe have his memory checked, because things that don't always have with the memory itself as in number one there, but the mood has changed. Grandpa used to be very sociable and a docile individual, and now his personality has changed. He's different. What's different about him? And then they have behavioral issues, and they can be nice and pleasant 1 minute, and then they can be angry the next. There are many different dementias, but I'm going to cover the 4 most common types. Alzheimer's is number 1, and that is with memory loss. And the key with the Alzheimer's has to do what we call with plaques and tangles. There are amyloid plaques or protein plaques in the brain that don't belong there. They interrupt the memory, the ability for people to understand or to carry out conversations and words and so forth. And then there are tangles. The neurons are not connected in the pattern in which they need to in order to be able to provide language for the person. Vascular has to do with strokes. People may have a stroke or they may have what we call mini strokes. Lewy body dementia, people will have hallucinations and maybe even motor issues. And sometimes that gets where they're not sure if the person has Parkinson's disease because of those motor issues that the person has, where their body is kind of stiff and they're not moving easily, which is a hallmark of Parkinson's. And then lastly, or fourth, is the frontotemporal dementia, FTD. And this is the one where personality changes, language challenges occur. And this might be the number 1 thing that sometimes people will notice in their loved one, that there is something different going on here. With Alzheimer's being the most common, 60 to 70% of all the persons who have dementia have Alzheimer's. The early sign, again, is that short-term memory. They can remember long-term kind of things, what happened in their childhood, what happened at a wedding they went to, and that was a long time ago. But again, they can't remember what they had for breakfast. In late stages, and that's not only with Alzheimer's, but it's with all the dementias, there's a loss of independence, and then they will end up with a need for full care. Vascular dementia, being the second most common, can follow strokes or mini strokes. And sometimes with mini strokes, people don't know that they're having them. So they can have many of the mini strokes, and then they end up with a vascular dementia. The symptoms with that, and the dementias are so intertwined with some of the things, the behaviors that occur, that is a little confusing sometimes, even for the diagnostician, because with vascular dementia, if the person's had a stroke, they may have slowed thinking and trouble planning, inability or slowed ability to speak. So it is specific for people generally who've had a stroke, and many of us have worked with those type of patients as well. And Lewy body dementia, people will have visual hallucinations, and they're so scary for people. They believe that there is someone outside their window that is coming in and going to hurt them. So we need to be there as protectors for people who have these diseases, especially Lewy body. The REM sleep, or the rapid eye movement, where we do our dream sleep, that's disturbed. So they don't get restful sleep. They don't get a length of sleep that they need. So next day they sleep, or they are restless and then they're agitated and have behavioral issues simply because they didn't get the right kind of rest that they needed. And now a little bit more about that Parkinson-like movement issues. They're stiff to be able to move forward and slow. And also with that stiffness, they can fall easily. So these patients are fall risks for sure. So we need to protect them in that manner as well. And the last one is the frontotemporal dementia, or FTD. They have that early personality and behavior changes. And people who have been highly successful and were doing many things from an executive standpoint, And now they can't remember how to speak or what comes first and what comes second in those conversations. And they have behavior changes as well. The language is the biggest. It often affects younger adults. And by younger, we're talking patients who generally with regular or other kinds of dementias who have it in their 70s and 80s. FTD generally occurs with people under 65. But a caveat here is that dementia can occur at any age. There is no specific age limit for that because people as young as in their 40s and 50s have had dementia. Some of the behavioral clues when a person has dementia is that they repeat questions and stories. Now, the stories are repeated because they're most comfortable with those stories, because those stories are in their long-term, and that's down here, in their long-term memory, which is intact, and that's stored in the hippocampus of the brain. So they're able to repeat stories, and it'll be the same stories, generally, from their childhood or midlife, where they went to weddings and did a lot of different things. So they're so comfortable and they can hold great conversations. The thing that we need to do is to listen, because they will repeat and repeat. They'll also repeat questions for you. And that is, what time is it? Where are we going? Who was here this morning? Who was had breakfast with me this morning? And you can say it in 2 minutes, if not sooner. They will ask you again. And your job and my job is to answer it. And they have mood swings with paranoia and agitation. Again, depending on if they had rest or if they found something that they think that someone has stolen from them. They had money in the drawer, and now they're paranoid about that because someone has stolen. They think someone has stolen their money, and they become agitated because of it. So we need to be able to work with the person and be where they're at right now. We can't just say, well, no one stole your money. They believe that someone did, and we need to ascertain how we can help calm them and be in their reality. Getting lost in familiar places, as I mentioned a minute ago, that they have always gone to the store, or they've driven to the store. They may even be working individuals at this time, and they lost their way on the way home. They can't figure out how to get there. The streets are looking not familiar anymore. And then again, that long-term memory in the hippocampus, the information, it's there. And that's such a great opportunity to be able to talk to people, and they have stories to tell us. They may have dementia, but they have some great information if we listen. Now, dementia, why don't you want to believe it could be me or it could be you? Well, there was a stigma about persons who've had dementia many, many years ago. The stigma had to do with simply because we didn't have a name for dementia, and people were called cruel names, which was terrible. They were called crazy, they were called stupid, and they were called demented, senile. So they go underdiagnosed because of that stigma. And late presentation means they're not going to get medications or therapeutics that would really help them. Many people are in denial. It can't be me. I'm just getting old, so I'm losing my memory a little bit. So they're in denial that it could be more than just aging process, because dementia isn't a part of the aging process. It's not normal for aging. And disengagement, the disengagement has to do when people live alone and we don't have a lot of people visiting. No one's really going to notice that they might have dementia and then help them. So people disengage, they stay alone, they get depressed, and they're not going to be helped with medications or other therapeutics as well. So why does early detection matter? Well, symptoms can begin as early as 20 years or more earlier than those visible signs show up. So someone in their 30s and 40s could be already having dementia periods in their brain, but there aren't really any signs or symptoms showing up at this time. The earlier we can diagnose, the better planning, treatment, and safety for the person. And we can get in there and start treating the person if we can get them in for good diagnostics. And it all starts with awareness. If we're not aware of something, we just go on with our life, don't we? And maybe these people down here in this video are looking like, well, we're older. We don't need to have helmets on our head. Nothing can happen. But awareness is for everyone, not just certain people. Well, we have more than 85 billion neurons in our brain. So you would think that would be plenty to carry us through life and not get dementia at all. But as I mentioned earlier, the beta amyloid proteins that are in the brain don't belong there. The tau tangles, they aren't helping the brain to communicate. So even though we have all those neurons in our brain, they aren't connecting and they're not working together on a cell-to-cell level. And that's what, when I talk in just a moment, talk about some medications. So how are the persons diagnosed? We need to do some functional testing as well, but we start with a primary care evaluation. Here in the United States, we do have, and I know that they're in other countries as well, not only MD physicians, but nurse practitioners and physician's assistants who can do this basic type of care evaluation very, very well. They use cognitive screening tools that are standard of care. And then once they go through the primary care evaluation, they go to a neurologist who will do further testing. Now, with the functional testing, we want to see how people are dealing with and coping with daily life. So if the person can't, cook easily or well, they're not going to have good nutrition, and they're also not going to be safe. To get some of those questions answered, we can lean on family to tell us, well, how are they doing at home? And go through a whole gamut of questions for them. And then brain imaging, MRI or CT, and not only if needed, because it really is needed, what if this person has a brain tumor and we're treating them for dementia? We need to do these tests in order to be sure. And also not only with brain imaging, but also with blood markers as well. What if they have a thyroid issue that can mimic the kinds of problems that a person with dementia has? Also, vitamin deficiencies can do that. So there is a lot of testing that really does need to be done to validate that diagnosis. Now, can they live alone? If they're living at home, we have to assess safety, which is number one. Are they taking medications? Can they take their medications on a daily basis like they're supposed to take it? Or are they not aware and they're skipping medication? Sometimes just putting together medications for the week, Monday, Tuesday, Wednesday, and they can and they do go ahead and safely take care of their own medication. And then I mentioned about cooking, for example. Are they using the stove properly? Are they turning the burners off so there isn't a fire or an explosion that occurs because they're not aware that they need to turn those burners off? And how we can help with that is to take those burners away if we think that someone should not be using the stove, and so many more things that we can protect the person from. Are they still driving? Maybe this is the time that we're going to have a key and car conversation because they've been in an accident Now, we don't want them to hurt themselves or others, so we need that conversation. Are they wandering? And not only in their own home, but do they leave doors unlocked? And then they're wandering outside. They're going down steps and they could injure themselves or get killed. And then you hear stories about people who have dementia and have wandered outside, down streets, and into ravines. And the worst has come of that. So we need to just be aware of that could happen. And if it is unsafe, then we need to begin care planning. Now, the family, in my estimation, is the best place that the person can be. And that is if they don't need a higher level of care. Family is always the best. And if the family can't care for them, then home care, the person coming into the home several hours a day, or maybe just at daytime to help them out. And then if not, a higher level of care could include assisted living or a nursing home. Now, what are the prevention strategies? We need to, again, control our high blood pressures, diabetes, and don't let the blood sugars spike. And if we have prediabetes, to work on that diligently in order to not develop into diabetes. Stay mentally and socially active. That is one of the hallmarks of dementia care, and that is to have people activate their brain with brain games and activities, exercise, that sort of thing. Now, protect our hearing, great depression. It seems that almost every patient who has dementia, somewhere along the way, ends up getting treated for depression as well. And in protecting the hearing, we want to make sure that people can hear, that they want to socialize then because they're able to actually hear conversations. And maybe then that is the reason why they're not conversing. Brain enhancing nutrition, so extremely important. Get the proper nutrition to the brain because it really needs nutrition. And also wearing helmets, and that starts when our kids are really little. So we want to prevent head trauma. Over and over and over, concussions do not do the brain any favors because as time develops, we lose brain cells. And due to those injuries, then end up with dementia. We can prevent this. So let's all work on that. So some new strategies on the horizon: early detection, exercise, whether the person can do it in the chair or stand up, but if they can only move their legs and arms sitting in a chair, better than nothing. The therapeutics and medication kind of go hand in hand. In the United States, we have donanemab and lecanemab as far as FDA-approved medications. The one thing about these two medications is that they changed the disease progression. But in order for that medicine to be given to the right person, it is for Alzheimer's. And you have to prove that the person has the amyloid proteins, because that's what the medication is targeting. So we need to prove that that's the right medicine for the right person. And that's done via a PET scan or a spinal tap. There are other medications that are used and are approved by the FDA, and they're for cognition and memory, such as rivastigmine, memantine, donepezil. And there's another one that has to do with communicating cell to cell, and that is for those tangles, the tau tangles, and that's Aricept. Now, sometimes people aren't going to be taking these medications because they started and they have a few little side effects. Well, just about every medication has something that if we look at it, might be called a side effect, but it's non-toward effect, perhaps. That's why working very closely with the physicians or the nurse practitioner, because the persons may complain about dizziness or nausea, headaches, that kind of thing. So they need to be closely monitored. Again, nutrition, extremely important, and socialization. In summary, we need to have early detection, prompt testing, timely diagnosis so we can get medications on board, and proper individualized interventions. Because one medicine is not good for everybody. It's individualized, although many people are using obviously the same medications, but people may be in different stages of their dementia or Alzheimer's, and they may require different medication. So what can I do for you? I want to support education and training. I want to share a global perspective, and that is sharing with you and you with me what is going on out there in dementia care with people around the world. I want to be able to provide resources and collaborate with you. I want to share effective care models because there are many care models out there as to how we work with and treat and intervene with dementia persons. And there's the medical model, the Montessori model. Well, whatever model any of the, let's say, nursing homes are using, the main key with that is that everybody's on board. Everybody's using the same model and working hand in hand to work with dementia persons. And then I want to be an ally in awareness and advocacy. This is my passion. I am fully invested in working and learning more myself all the time and being an advocate for those who they can't talk for themselves sometimes. They can't advocate for themselves. It's up to us to do that. Sharing hands across the world, well, we will be able to care for all the brains across the world. So thank you, Dubai, and to all the professionals, the caregivers, and dementia supporters out there watching worldwide. You deserve up-to-date knowledge, and together we can ensure that those with dementia are cared for with dignity, compassion, and expertise. So thank you very much. I appreciate being here today.
Thank you so much, Miss Ellie. I think that was something we needed to know about dementia and challenges that these people face from in day-to-day life. And the reality is really, really, it's a suffering, right? It's something that we don't want anything like who we know to go through with it. It is something that makes them lonely, makes them very depressing. I've known patients to have gone through moments where they don't want to continue to live, to give them that hope that it is okay and there is support. I think letting them know that we are there to support them is the greatest what we can do for such patients. Ma'am, just one thing I just wanted to know that sometimes these kind of symptoms can come a little, like as you mentioned, it can start even early, as early as maybe from 30 years old, right? Like a patient who is starting, it might be the smallest things that they start, forgetting the small things or some small things, maybe misplacing stuff or even not remembering certain things. So those might be the starting signs. Do you feel like people, I've read about it, I don't know how much of it is actually possible, like there are these exercises that people recommend, like to recall at the end of the day, to recall what all you have done or what all you have been doing in an entire day, maybe to keep a record of it, making your brain like sort of like a brain exercise if you want to know. So is it of any use? Can you, like, in some way, the small symptoms that comes up, can it be recovered in early stages, of course, by doing something like this, recollection games, or you in online also, so many of these things are there to activate your part of the recollection and to improve your memory. Can it help actually in some way?
Well, it is known that that is true. And there is something that we would call intentional remembering. And how many people get lost in the parking lot when they go into the store and they come back out and they can't find their car? They don't all have dementia. It happens to me, but what I've done is to make sure that when I get out of my car, I'm intentional about knowing where it is. I look at the sign on the top of the storefront, and that's where my car will be when I get out. So practicing different things and also doing games that stimulate. We hear about people that use puzzles and things, but brain games, there are so many of them out there. You can Google it and you can find a million of them, but not all of them are good for everybody because some people lose patience with it. So you have to know the person and know that that's something that they will, really want to do. But we can stimulate the brain in so many different ways. And trying to remember where I put my keys, be intentional about having a certain spot for it and always taking it out of your pocket, putting it there. So if we throw them in different places every time we come in, we're not going to be able to train our brain to go back a step, another step. That's where I put them. And it makes you feel more comfortable too, because you know that you have control over those things and you will be able to remember it then. And sometimes going into a room, and I went in there to go get this book, but then I went in there and I got distracted and I don't remember why I went in the room. It does happen to a lot of people, and not everybody has dementia who can't remember certain things. So I think we need to let people know that too, that there is an evaluation process that needs to go on and not jump to conclusions and say everybody has it because they can't remember.
I think we through this we can understand the importance of awareness, like professionals as you coming out here and telling that this is not a problem, this is something that you need to, it's partly being responsible, being intentionally remembering, and not a disease. It's also important for people to understand that it won't create a problem. Anyway, it was really interesting to know about these insights, and the presentation is open for discussion. Any questions, any queries, please, you can ask Ms. Ellie about it.
I wonder if Ms. Leclerc has an opinion whether using the term neurocognitive disorder is a little bit more gentle and doesn't have the implications that dementia has had in the past as far as being stigmatizing. It indicates more of an organic basis just from the title.
Well, I think you're right about that too, because we use terms such as neurodegenerative. And sometimes that term can make it sound like I'm a degenerate. And that is a negative implication rather than a helpful one. So, neurocognitive decline, when we use these other added words to it, it gives the impression that, well, there's probably no help for me. So, I guess it's on an individual basis and how we gently provide the information. And like a speaker said before me, indicating, each person is an individual and we have to take them into consideration as a whole person and how it's going to affect getting that news. And sometimes people are in different stages by the time they get to the diagnostician, and they don't know that they're given bad news, which sounds terrible because they can't they can't participate now maybe in their care. So it's going to be a relative, a family member that's there. So we have to look at how we give that news to them, what words we use, what terms we use. But there is so much verbiage out there now, but there is less awareness sometimes than I would hope for, because people tend to let it slide because they're young and looking at grandpa or the neighbor or so and so, but they're not looking at it for themselves. And we need to make awareness for ourselves. And no matter how young you are, Doesn't mean you're getting dementia, but maybe your grandpa has it or your parents have it, and now we want to be able to be prepared. So the right words, you're right. The words are carefully chosen, and it would depend on the person. And, do the people that you're talking to understand what this really means? Or to say the word Alzheimer's, it's scary. It's very scary for people. But if we told someone they had a heart attack, they'd expect us to take them to the cath lab as quickly as possible and heal them. So they're scary for a moment, but they know that they're going to be healed and they're going to come back out and their heart's going to be just fine. But somehow when we talk about the brain, it's the scary part that it's not going to get better.
Yes, it's so rightfully told, Miss Ellie. I hope the doubt
Thank
is clear.
you.
Again, thank you so much, ma'am. Any other questions?
Thank you for the question.
Thank you, Miss Ellie. I think that'll be it. Thank you so much for giving insights into this disease and everything about it. I think awareness is a key to, finding out more and keeping ourselves updated about what to be done and getting yourselves diagnosed. Thank you so much for being a part of this conference. Really appreciate it, despite the odd timing that you are on. I'm very sorry. Apologize for the inconvenience.
Thank you. Appreciate it.
Thank you so much. Thank you. Thank you.
Good night.
We have our next speaker. That is, I would like to welcome Mrs. Dr. Jimna Alvarez del Castillo Gonzalez from the Royal Marsden Hospital NHS Foundation Trust, United Kingdom. She will be presenting on the topic enhancing patient knowledge and confidence in post-surgical self-care, a quality improvement project. Please join me in welcoming Dr. Jimena, and we would love to hear her share her valuable insights with us. Welcome, Doctor.
Hi, thank you very much for the introduction. I'm just trying to share my screen. This makes it a bit sense.
Yes. Can you please share the slides, please?
Give me 1 second. Open the presentation. Perfect. Can you see my screen?
Not visible as of now. Can our team play the slides? If it's
Well, I'm sorry about this. I don't know why it's being a bit difficult with
it's okay. Our team can share the slides. Is that okay?
Okay. Yeah, that's completely fine.
Yeah. And yeah, you can say when you need the next slide, okay? You can just tell the next slide and it will be.
Okay. I can't see it.
Your screen is visible now?
Oh, my screen is visible now. Oh, okay.
Yes, yes. So
So,
you can play the slide. Yes.
okay, you can see the slide. Perfect. Sorry about that.
Yeah.
So basically, I'm going to talk about a project that we worked on our hospital. And it was basically, well, we named it as a way of enhancing patients' knowledge and confidence in per-surgical care. It was a quality improvement project. So a brief summary about why we decided to do this project is because some patients gave us some feedback about specifically colorectal patients that they wanted more information when they were going about their surgical care, specifically when they were at home. And in certain areas, 5 specific areas where they were having a little bit of like questions once they were home. So the main areas that they expressed decided to learn more about care was basically in wound management, pain management, stomach care, dietary advice, and point of contact to the team in case they need help. So this project aims to address common gaps in knowledge, specifically in the post-operative care following colorectal cancer surgery. So we intended to implement strategies to enhance their overall experience. We first started by conducting a survey to get feedback from patients that we operated between January and September 2023, and we asked them about how we were doing, what was the way that we were giving them information, if that was the right way, or if they wanted to get more information about
Doctor,
yeah.
Dr. Jimna, I would just like to interrupt you in between. Actually, our team is playing the slides. So once a slide is over, you can just say next. We can't access your slides actually. Yeah. So you can just say next and then they will move to the next slide. Okay. Now we are on the brief summary, right? The slide with the brief summary. Yeah, you can kindly say next and then the team will put the next slide. Thank you so much. I'm sorry to interrupt. I'm sorry to interrupt.
So the next one, please. Yes, perfect. So yeah, the way that we decided to do this project is by gathering the surveys from patients that we operated. We asked them about their experience, about the indication that they were receiving in this specifically 5 domains. We asked them as well the preference of how they wanted to receive the information once they've been discharged. So based on that feedback, we worked together with a multidisciplinary team of stomach nurses, pain team nurses, dietitians, and healthcare providers from the colorectal team in developing a material, specifically a leaflet, with this information that would be useful to our patients. We also included a section where we wanted to offer psychological support. Next one, please. So after the leaflet was created and we gave it to the patients and we explained it, we conducted a survey between mid-March to April 2024, just to ask a little bit more about how they felt with this information. This was given before they left the hospital, and 2 weeks after, when we used to see them after the surgery back in clinic, to assess how did the leaflet help them, and if this leaflet resolved most of their queries once they were in their home. So we had really positive outcomes. So from the first survey, we got 33 feedback forms, and after the leaflet was given, we got another 15 feedback from patients that received the information. So before the intervention, patients express or they score a 7 out of a 10 in all the 5 domains. And after the implementation of this leaflet, they score about a 9 on average. So pain management, stomach care, they had a similar outcome. It was between before the intervention and 8.7. After the leaflet was a 9.27 approximately. Wound management was from an 8.12 to a 9.3. And the most important one, or the one that outstanded, was specifically the dietary advice, the jump from a 7.39 to a 9.20. And while contacting the team as well, it went from an 8.27 out of 10 to a 9.40. Next one, please. And when we asked them about how they wanted to receive this information, 87% of the patients expressed that they wanted a face-to-face advice. Then 43% they said that they wanted an electronic or a digital way to receive this leaflet. This instructions, because 40% decided that a physical leaflet would be useful. 18% decided that mentioned that a phone device would it be the way that they wanted to receive instructions, and 15.6 they decided to choose online videos. So in the first post-intervention survey, all of our patients agree that this leaflet helped them to resolve most of their concerns before leaving the hospital. And in the following survey, 2 weeks after discharge, they also agreed that when we asked them about how did it go, they also agreed that the information in the leaflet helped them to resolve most of their concerns when they were at home. Next one, please. So in conclusion, we can highlight how important it is from healthcare providers to provide information, and the communication between patients and the healthcare providers, how it's essential to create that bridge, and also how that could also reduce levels of stress while the patients are at home, and then they can feel that they have some material to rely on. Also providing like specifically materials targeting different areas that they could face trouble when they are at home, can also, specifically in life-changing colorectal cancer surgeries, can also enhance their experience in and promote the patient autonomy. Next one, please. So the future actions from this project that we find out that how important is the providing information and to the patients when they've been discharged from the hospital, but also what about the preoperative section? So before they come into the hospital, how well are we doing in giving them that information of how, you know, the steps that they're going to follow up the moment they've been referred to a cancer hospital? What are they going to face? Who are they going to talk to? What, you know, the studies that they're going to go through, say scans, blood tests, who are they going to face? So based on that, we're moving on as doing some projects in terms of it's called bowel talks, and this is the whole aim of trying to provide this kind of information about what they're going to face, reliable information about what they're going to face. And also we want to implement this leaflet, or well, we're implementing this leaflet not only for colorectal patients, for any post-surgical patient. So that's where we are working on in trying to create a more comfortable environment for patients who go through these major surgeries. And that's pretty much everything. Thank you very much.
Am I audible? Am I audible?
Yes.
Yeah, thank you so much, Dr. Jimna. I think that was something interesting to find out, like post-surgical results. And if you can discuss something about the effects on their mental well-being as such, post-surgical after certain situations, they might go through like anxiety disorders or post-traumatic disorders, or, some kind of depression that they go into post-surgery. Do you know anything about it, or how can we cope with it? Mental well-being as well.
It's a very interesting question, because in part of our survey, we asked if the patients wanted to receive some psychological support, or they will benefit from some psychological support, specifically in this life-changing surgeries. And I recall that it was more than, I would say, 2/3 of the answer, they said no. So it's a very interesting way of seeing it, how sometimes if we find a way to just take out that stigma about, like, well, you will face situations that will affect your mental state. There are some options that we can offer you, some psychological support, maybe not rephrasing it, not naming it as psychological support, maybe like therapy group, or sessions where you can talk to other people who have been going through the same problem or the same surgery, and how that could also help them with their mental health. So we definitely have, after specifically for colorectal patients, we have this sessions where you provide some like therapy, or, well, yeah, it's therapy, but it's just try to rephrase it in a way that stigma is not, that the name of therapy doesn't like cause them to, oh, I need to go to see a psychologist, and because of all the stigma that's related to mental health. So definitely it's a quite important thing to keep working on, and finding strategies to civil and friendly for anyone to go through, specifically any major surgery or cancer related.
Thank you, Jimna, for your response. The presentation is now open for discussion. Any other queries, please do ask your questions now to Dr. Jimna. Any queries? I think that'll be all. Thank you so much, Jimna, for your time. Again, for the time, the difference that you are in, the time zone you're in. Thank you so much for coming and being a part of our conference. Okay. Now, moving on to the next speaker, I would like to welcome our next speaker. The following speaker is Dr. Gerald H. Katzman from Wayne State University School of Medicine, USA. With a distinguished career in pediatrics, he has contributed extensively to child development research. His presentation is titled Child Development Leading to the Pursuit of Virtues and the Avoidance of Vices. Please join me in welcoming Dr. Gerald. Welcome, Dr. Gerald. You can start your presentation.
Thank you very much. Thanks for having me. And yes, I will be discussing child development leading to the pursuit of virtues and the avoidance of vices. I'll start by sharing my slides. Okay, you can see the slides now? You can hear me and see the slides? Okay. Now, optimizing social, emotional, moral, and cognitive development for all children is a goal towards which most individuals would agree is worth striving. Such an achievement would likely solve many problems that humankind confronts on a global basis. Examples of these problems include domestic abuse, avoidable enmities, some mental illnesses, crimes, wars, genocide, and others. Attaining benevolent mindfulness is a key result of any process leading to mature, healthy character development. At the same time, avoidance of insults that lead to selfish, malevolent behaviors is critical if human potential is to be optimized. This paper is meant to provide a roadmap to the process of fostering child development so that virtuous, helping behaviors are the rule and vices actively avoided. See, I'm going to have to get down to the bottom and get back to the top. Okay. Okay, so experts generally agree that authoritative parenting is critical to the healthy mental development of children. With this type of parenting, confrontation with responsiveness characterizes the approach to discipline. Confrontation involves identifying and counseling regarding misbehavior. At the same time, recognition and management of stress associated with misbehavior and certain life events is regularly attended to in order to prevent long-lasting adverse mental sequelae. Shaming, coercion, intimidation, and corporal punishment are not utilized as they are in authoritarian parenting. This is to avoid the toxic stress that is a product of preventable adverse childhood experiences. With authoritative parenting, the communication setup between parent and child leads to healthy interpersonal attunement that serves developmental progress. Unfortunately, authoritarian parenting often is passed from generation to generation. Adverse sequelae, including mental illness and violent behaviors, are often seen. For this reason, an active effort to break the cycle of authoritarian parenting and teach authoritative parenting is vital. This effort may start while couples are attending prenatal education classes. In societies where authoritative parenting is not the rule, a child development team may be organized to promote desirable parenting practices. Lastly, permissive and uninvolved parenting also need to be avoided due to the lack of direction for desired behaviors associated with these parenting types. Now, with authoritative parenting, reciprocal communication between parent and child is established. In the newborn, this begins with en face or eye-to-eye contact, especially during feedings. Later, it may involve reciprocal smiling, singing, talking lovingly to the infant, and play activities before elementary communication with language is possible. The interpersonal attunement that develops describes how caretaker and child are responsive to one another's emotional needs, thoughts, and moods. When well developed, this interpersonal neurobiology involves a resonance where the thoughts, needs, and feelings of the other are regularly appreciated. Appropriate responses are often the result of such attunement and lead to the strengthening of the bond between caretaker and child. Now, imprinting describes a situation where a young animal comes to recognize another animal, person, or thing as a parent or other object of habitual trust, often shortly after birth. In humans, we usually use the term attachment to describe the trusting relationship that develops between child and caregiver. This trusting relationship strengthens over a period of months to years due to ongoing interpersonal attunement with caregivers being responsive to the child's needs. In order for attachment to be successful, an initial bonding of love and tenderness the caregiver feels for the infant needs to occur. As Andrea Hollingsworth has stated, over time, secure, attuned attachments with other persons may enable us to love more and fear less, rendering us progressively more capable of sharing in the suffering of others and increasing the likelihood that we will take action to alleviate that misery. It is these secure attachments that allow caregivers, teachers, and mentors to influence the child's developing mindfulness or intrapersonal attunement. Now, intrapersonal attunement or mindfulness involves noticing and respecting oneself. It refers to a self-regulation of attention where one pays attention to the events of the moment. This process requires an orientation to learn values represented in cortical areas of the brain. Intrapersonal attunement enhances the capacity for emotional empathy. If certain values related to a particular circumstance are internalized, it is clearly necessary to provide a moral learning process that will enhance emotional empathy and serve as the impetus for helping behaviors. Developing a moral compass should insulate persons from blindly following a group who are caught up in inadvisable behaviors. This moral learning should provide protection from de-individuation, so characteristic of authoritarian societies. Now, moral learning can be transmitted in a number of ways. Basically, the exercises involve either classical or operant conditioning. Every effort should be made to eliminate the corporal punishment and shaming that are commonly used by some, quote, educators in certain situations. Such reinforcement often results in repressed fear and anger that serve as a well of energy waiting to be discharged on targets that may be established by false narratives. Moral learning is taught by either dilemma ethics or plain moral facts, with several vehicles commonly used for such teaching. These vehicles include the modeling of caring behaviors, reading stories with a moral, and human relations programs for children. Moral decision-making that results from such learning becomes emotional, intuitive, and automatic when dealing with a familiar issue. Alternatively, decision-making may involve conscious, controlled reasoning based on prior or new learning when an unfamiliar moral issue is encountered. Now, Samuel and Pearl Oliner's study, published as The Altruistic Personality, found that persons who modeled caring behaviors inside and outside the family were more likely to have children who would take significant risks to help others. Specific suggestions and techniques for modeling desirable behaviors are available through a number of sources. At healthychildren.org, suggestions include pointing out sharing among adults, showing ways to calm down, teaching children to express their feelings, and paying attention to good behavior. At klaschools.com, suggestions for modeling involve doing good deeds, being patient in lines, respecting others and their property, and being a good loser. Other sites also contribute constructive ideas. Now, literacy is key to all learning. Early vocabulary growth comes with parents speaking frequently with their children. Brain growth is impaired when less words are spoken to children. The 0 to 3 program and others provide parents ideas for nurturing thinking and language skills. Unfortunately, across the United States, less than 50% of children are read to daily by parents. The Head Start program in the United States provides a vehicle for disadvantaged children to, quote, catch up. However, the program is inadequately funded and staffed to serve all of the many children in need. This lack of learning and impaired literacy in the early years may hinder the attempt to transmit plain moral facts through reading and telling stories. That is why promoting early literacy has the potential of enhancing the moral and social emotional development of children. There are many resources that caregivers and schools may use to promote moral learning as children mature. For the lessons to be appreciated and internalized, it is obvious that comprehension is mandatory. Now, individual differences and experience in human relations for children is an example of a compendium that outlines exercises at various grade levels to sensitize children to appropriate interaction with others. Multiple goals of the exercises include furthering self-esteem, supporting virtues and avoiding vices, control of emotions, awareness of human similarities, and respect for individual differences. A number of recent resources are available to teach respectful human relations. Many school systems do an excellent job in this area. However, it should be emphasized that there is a degree of moral entrepreneurship in all these programs. Such moral entrepreneurship involves expressing an opinion as to what is virtuous behavior and what behavior should be avoided, example, vices. In this regard, virtues are defined as those traits of character that blunt mere self-interest so that one can see and actively promote the interests of others. In contradistinction, vices represent those traits of character that unleash mere self-interest, so that one fails or ignores to see the interests of others. Certain cultures may vary somewhat in their concepts of virtues and vices. Teaching and agreeing on plain moral facts should be achievable. Now, false narratives have classically been a vehicle by which societies have attempted to direct members to accomplish their own selfish purposes. Such false narratives may distort history, promote false beliefs, and propagate negative feelings towards ethnic and racial groups for political purposes. It is anticipated that healthy psychosocial development that includes authoritative parenting and moral learning will shield persons from internalizing these false narratives and contribute to resilience in stressful times. Higher levels of literacy developed through the educational process should further facilitate the process of, quote, reading between the lines. There are communication skills that include attentive listening, assertive statements, and clear opinions that are essential to the success of nonviolent conflict resolution. Human relations programs for children should provide the basis for the objective thinking required to reduce enmities that have developed. Now, emotional empathy refers to the vicarious sharing of emotions. The ability to feel the emotional states of others is based on the quality of interpersonal and intrapersonal attunement experienced during development. Dr. Helen Reese has developed the concepts of empathic concern and empathic capacity. It is secure, attuned attachment, modeled behaviors, reading stories with a moral, and human relations programs for children that contribute to enhancing emotional empathy. Unfortunately, interpersonal relationships marked by conflict, insecurity, and distrust can cause us to feel threatened, emotionally deregulated, and closed off to empathetic connection with others. There are many examples where recurrent maltreatment in childhood that results in fear and anger produce a stifling of emotional empathy. The presence of cognitive empathy, the ability to mentalize without emotional empathy, is characteristic of psychopathy, where ruthless persons use others as objects to satisfy their own selfish needs. Now, emotional empathy allows one to feel the suffering of others. Moral learning creates the impetus to care about such suffering. The result of feeling one's suffering and caring about it is the desire to relieve the discomfort. That desire we define as compassion. It is compassion that leads to helping behaviors that ultimately relieve the suffering. The propensity to work towards helping behaviors is clearly dependent on the quality of experiences during psychosocial development. In conclusion, it is clear that optimizing psychosocial development is not a simple endeavor. If we are to achieve parenting for a peaceful world, significant initiatives are in order. Parenting orientation prenatally has been shown to be effective. Pediatricians can provide ongoing support to children and parents in the office if their services are readily available to all. Certain genetically transmitted conditions, mental disorders, congenital problems, and injuries require ongoing medical and community resources for the best possible outcome. The United Nations Convention on the Rights of the Child could provide a vehicle to further developmental education globally. There is much work to be done as the child advances through the school system. That work includes contributions from teachers, theologians, pediatricians, political leaders, and other community members who serve as role models for civility and responsible behavior. Indeed, it takes a village if psychosocial development of children is to be optimized. For progress to be made, countries need to provide the person power and financial resources to facilitate traversing the steps that will be outlined in the next flowchart. Prioritizing efforts to achieve such progress is a challenge for all societies. And I'm just showing here the slide for benevolent mindfulness. And you say we start with authoritative parenting and interpersonal attunement that results in secure attachment that does impact emotional empathy and enhances emotional empathy. With secure attachment, reading stories with a moral that teach a lesson become possible, modeling caring behaviors are instituted, and interpersonal attunement, as I say, is enhanced by these modalities. And also, as the child gets older in the school system, human relation programs for children also impact the interpersonal attunement. With emotional empathy and the enhanced moral compass, compassion can develop, and this compassion leads to helping behaviors. Human relations programs for children also will assist the resistance, the ability to resist false narratives, and provide the skills necessary for nonviolent conflict resolution. Let's see if I can go back here. Now, where we don't want to go is to malevolent mindfulness. And that often starts with authoritarian parenting, which results in repressed fear and anger. This is the toxic stress. Permissive or uninvolved parenting in the presence of an authoritarian culture, also with the stress that occurs from the authoritarian culture can result in this toxic stress that results in a stifling of emotional empathy. With that stifling emotional empathy, targeting by false narratives can occur in the culture, and hatred development may occur towards various ethnic or groups or other countries, other societies, and this can be reinforced through false narratives and sometimes by coercion, and that results in violence. And also what happens is the idea that to not go against the group, and this is the de-individuation, and the group together it gets involved in violent activities. So this is something we certainly want to avoid. So I'm going to stop sharing right now. And I want to show one more, if I'm successful here, in showing one more very short YouTube that demonstrates interpersonal attunement. See how this will work. Okay. All right. Here we go.
So are you having any technical difficulties as of now? Sir, doctor?
It's a very, can you see this?
No, actually, no, nothing is.
Oh, I see. Let me do this. I'll start it over
Okay.
again.
Yeah,
I'll start it over.
okay.
What's that? All right, I need to minimize this and then I'll share.
Are you sharing a
Uh,
video with us, sir?
yeah, I'm going to do it in 1
Okay.
minute now.
Okay, sure.
If it's share. Oh, I'm afraid I lost the video. Oh, no, here it is. Let's see if this will work now. Yes, okay.
Yeah, okay.
Let's get back to the start.
I think the audio is not available.
This is something that we started.
Okay, sir. I'm sorry, doctor, the audio is still not available.
Not good? Oh, wait a minute. All right, let me try one more time.
Okay.
I stop the share. Okay. Oh, I forgot this. All right, let me
Okay.
share again. All right, oh, here should. All right, this should work now.
Up
Okay.
in front of her
All right,
and
I'm gonna get back to the
says,
beginning.
"What's
Yes,
happening?"
the audio is audible.
She makes that screechy sound at the mother.
I'm gonna get back to the beginning. We'll start again.
Like, come on, why aren't we doing this? This young are extremely responsive to
Okay,
the
doctor.
emotions and the reactivity and the social interaction that they get from the world around them. This is something that we started studying 30, 40 years ago, when people didn't think that infants could engage in social interaction. In the still face experiment, what the mother did was she sits down and she's playing with her baby, who's about a year of age.
I'm like a girl. Oh.
And she gives a greeting to the baby gives a greeting back to her.
Yeah.
This baby starts pointing at different places in the world, and the mother's trying to engage her and play with her. They're working to coordinate their emotions and their intentions, what they want to do in the world. And that's really what the baby is used to. And then we ask the mother, to not respond to the baby. The baby very quickly picks up on this, and then she uses all of her abilities to try and get the mother back. She smiles at the mother. She points because she's used to the mother looking where she points. The baby puts both hands up in front of her and says, "What's happening here?" She makes that screechy sound at the mother, like, "Come on, why aren't we doing this?" Even in this 2 minutes, when they don't get the normal reaction, they react with negative emotions, they turn away, they feel the stress of it. They actually may lose control of their posture because of the stress that they're experiencing.
Okay. I'm here. And what are you doing? Oh, yes. Oh, what a big girl.
It's a little like the good, the bad, and the ugly. The good is that normal stuff that goes on, that we all do with our kids. The bad is when something bad happens, but the infant can overcome it. After all, when you stop the still face, the mother and the baby start to play again. The ugly is when you don't give the child any chance to get back to the good. There's no reparation, and they're stuck in that really ugly situation. Babies this young are extremely responsive to the emotions and the reactivity and the social interaction that they get from the world around them. This is something that we started studying 30, 40 years ago, when people didn't think that.
Yeah.
Okay.
Yeah, doctor. I think that was a very insightful video.
Yeah, I'm trying to. Are you still hearing it?
No, the screen sharing is off for now.
Okay, because I'm hearing it here, unfortunately.
Okay.
Okay.
Thank you, Dr. Gerald. Thank you so much for that presentation. I think for all the parents, I think not just the parents, I think even the clinicians dealing with children at this age, for the pediatric dentist as well as the physicians, I think it will be of a lot of help, like when you understand the beginning stages, right, of a child. And myself, I'm a mother to a 5-year-old, and I can totally understand the kind of struggles that I've gone through with when my child was developing. And I just want to ask you something about the speech delays that you find very common, especially post, I could, if I have not mistaken, post the COVID era, the post the COVID years, many children having so much difficulty in the speech development, delays that has been very common. I don't know, are there any reasons that you can tell, whether it's social things that are affecting their delays, or and how we can cope up with those?
For one, I mean, socialization and that interpersonal attunement that we have with peers and with mentors is critical for ongoing development. And unfortunately, and that I think it's probably what happened during the COVID situation with basically relative isolation. I think the biggest problem today that we deal with in the world is the authoritarian manner in which some societies are conducted and parenting is conducted, and that's where we get this de-individuation, this ability to go, the desire to go with the group. And if the group is doing inadvisable, violent things, we have tragedies.
That's true. So you told about the kind of when you are training the children, the violence that is there within the like it could be as small as you're punishing them for something that they're not doing or something like that. How harmful could it be for the child? Like when you have parents who are constantly in a motion of yelling or assorting to such kind of violent kind of reaction to the child. Maybe the child might himself be very naughty or very, very hyperactive himself, that, the parents find it very frustrating and then they are reacting to such thing. What could be the impact on such children? Yeah.
Well, it's terrible. And there are various examples through history now that we know about, and through cultural anthropology. If you take the Spartans, for example, in Spartan culture, there was the educational system was called the Agog, Agog, and it was an introduction to militancy, and the children were abused to, quote, toughen them up. And Aristotle commented that Spartan culture produced beast-like, specifically wolf-like people. And so Dr. Gilbert Hurd spent 2 years in the early 1970s with the Sambia of the Eastern Highlands of New Guinea. And it was a similar, extremely abusive child rearing that started at about 7 years of age with separation of the child from the parents. And violent warriors were produced. So there are some very clear examples that authoritarian, abusive situation with corporal punishment, shaming, coercion, certainly needs to be avoided. And if we're going to change societies and change the world, we need to teach authoritative parenting and stay away from the shaming, coercion, and corporal punishment.
Yes, that's very true. One last thing that I want to ask is that sometimes it's quite like we do read about certain people telling that parents are supposed to be parents and not their friends. To your child, you're a parent, and it doesn't mean that you're becoming their friend. Um I would definitely want a friendship to last between me and my children. But when some people say that it's not supposed to be like that, you're supposed to be their parent and not their friend. What do you think about it, being a pediatric caretaker?
Yeah, I think it's the learning process. The learning process does not have to be and is much better if it's not an abusive process. So that that interpersonal attunement, like was so dramatically shown in the Dr. Tronig's video, that's something that can carry on throughout life. And there are nonviolent ways of disciplining when the child is not behaving in the way that is expected. But again, avoiding the abusive ways of disciplining is critical.
Yes, very sure. So, anyway, it was a really interesting topic to actually be discussing upon, and you gave us a lot of information about personal attunement in children from a very small age, as young as they can be. And once again, thank you, Dr. Gerald. It's been a wonderful time talking to you. And thank you, despite the zone change, so much that you have put in effort and being at a very wrong time in your time zone. Thank you so much for being a
Well,
part
thanks
of this
very much for having me, and I will send you a paper that deals with this, and perhaps you can distribute that to participants.
Definitely. Thank you, sir. It'll be of great help. Thank you. Thank you, doctor, again. Thank you.
Entirely welcome.
So we will be moving on to the next speaker for the day. I would like to introduce Dr. Mesa Alomari. I'm sorry for the mispronunciation if it is there. So our next speaker, again, Dr. Mesa Alomari from Saudi Arabia. She's a dedicated teacher, researcher at Al-Andalus University for Medical Sciences. She will be presenting on her talk, which is titled A Global Review of Financial Inclusion and Social Determinants of Health. Again, please join me in welcoming Dr. Mesa Alomari. Good afternoon, Dr. Mesa.
Good afternoon. Hello?
Yeah, you can share your screen.
Lighting, please.
Lightning.
Hello?
Hello, good afternoon. You're audible.
Good
You can
afternoon. Good afternoon.
kindly share your screen. Yeah.
Are you hearing me?
Yes, doctor.
Yes. Good afternoon, everybody. I'm from Syria, not from Saudi Arabia.
I'm sorry for the technical mistake. Sorry.
Okay, no, don't worry.
Can you
The title of
share your screen?
yes, the title of our session today is about a global bibliometric review of financial inclusion and the social determinants of health. Despite the growing global emphasis on financial inclusion and social determinants of health as key pillars of equitable development, academic research has rarely examined their intersection. This study presents the first bibliometric analysis exploring the relationship between financial and SDH by examining 4,022 articles indexed in Scopus from 1973 to 2024. In recent years, financial inclusion, FI, has emerged as a critical instrument for promoting economic development, reducing poverty, and enhancing social equity. Defined by the World Bank as the access of individuals and businesses to useful and affordable financial products and services such as savings, credit, insurance, and digital payments delivered in a responsible and sustainable manner. Financial inclusion has become a central pillar in global development agendas. Importantly, it's recognized as a catalyst for achieving 7 of the 17 Sustainable Development Goals, underscoring its far-reaching implications across sectors. Do you hear me? Hello?
Doctor,
Hello?
you're audible. You're audible.
Okay.
Yeah, you can continue.
Okay. The SDH, as conceptualized by WHO, referred to the non-medical factors that influence health outcomes. These include the conditions in which people are born, grow, live, work, and age, encompassing domains such as income, education, housing, employment, social support, and access to essential resources. These determinants shape health inequities within and between population and are deeply embedded in broader social and economic structure. Emerging evidence and theoretical insights suggest that building access to economic and social opportunities. Access to financial services can reduce income volatility, enhance household resilience, and empower marginalized populations, particularly women and low-income groups, to make more informed and healthier decisions related to nutrition, healthcare access, and preventive services. Furthermore, inclusive financial systems can facilitate access to health insurance and improve mental well-being by reducing financial stress. Despite these theoretical linkages, research explicitly connecting FI and SDH remains fragmented and limited in scope. Addressing this gap, the present study conducts a bibliometric review to systematically map the scientific literature at the intersection of FI and SDH by analyzing publication trends, co-authorship networks, and keyword co-occurrence, thematic development. This review aims to uncover the field's intellectual structure, identify influential contributions, and highlight emerging research frontiers. This study contributes not only to academic scholarship by providing a comprehensive synthesis of a previously underexplored intersection, but also offers insights relevant for policymakers seeking to align financial and public health strategies to support equitable and sustainable development. Our methodology charts divided to 4 stages. The first stage is about planning and review. Our paper questions are 4. The first one, what is the current research landscape? The second one, what is the intellectual structure of this research field? The third one is which topics have attracted the most scholarly attention and which present the research front in the literature. The fourth one, what are the main future research directions? In our study, we use, as we said, bibliometric analysis to quantify and map the intellectual structure of the field. We use also content analysis to explore thematic details and identify future research directions. A 3-step analysis was developed to ensure transparency and reproducibility following established bibliometric guidelines. The second stage is about data collection. We use Scopus due to its extensive coverage of peer-reviewed literature across disciplines. As we said, the time span from 1973 to 2024, total articles retrieved after excluding duplicates, 4,022 records. In the third stage, we use performance analysis. I divided to two steps. The first step is about research trends. In this stage, I analyzed the annual publication trends to identify growth patterns in the field, and I defined the influential journals, ranked journals based on their contribution on the field. Also, I apply science mapping and content analysis. The last stage is about results and analysis. I use in this stage content analysis as key research gaps and future directions were identified through this analysis. D'accord. Through the program BiblioShiny, we can see here annual publications trends from 1973 to, sorry. Hello? Hello?
Yes, doctor. You're audible.
D'accord. In Figure 2, we can see annual publications trends from 1973 to 2024 in financial inclusion and social determinants of health research, showing the evolution of scholarly output in key growth periods. Figure 3 here, we can see citations trend analysis in the same period that shows an inverse relationship between citation impact and number of publications in research on FI and SDH. In our figure 4, most influential most influential journals in financial inclusion and social determinants of health research led by BMJ Open and PLOS ONE, followed by Cochrane database of systematic reviews. Here we can notice in Table 1 most cited scientific publication. We can see here that the most total citation was for the paper which titled "Managing the Health Effects of Climate Change," which published in 2009. In Table 2 here, I arranged the most contributing journal. Okay, here we can see that the BMC public health have the most impact factor, which is 10.6. In Figure 5, we can notice here that growth trajectory of annual publications post 2010 showing PLOS ONE and BMC public health as leading contributors by 2024, reflecting the rise of open access multidisciplinary research in addressing global health and financial inclusion challenges. In Table 3 here, we can see ratios of articles in study database according to key subject areas. Here we can see that all the database related to endocrinology, the diabetes, metabolism, public health, and environmental and occupational health. To study the nexus between financial inclusion and SDH in the literature, we conducted a 3-step review. We initially went through articles that addressed the financial inclusion theme from an initial pool of 4,022 papers. We screened 196 articles that addressed financial inclusion by applying a title-based filter in selected database. Our evidence shows that those digital technologies such as mobile banking, digital wallets, and fintech innovation have significantly expanded financial access, particularly in developing economies. Second, we analyzed with a focus on articles that address social determinants of health directly. Out of 4,022 documents, just 94 papers were found to be associated with this particular topic when applying title-based filter in the selected database between 2014 and 2024. Third, we reviewed articles that reported on the overlap between FI and SDH. A comprehensive review articles retrieved from the Scopus database revealed a striking absence of studies that directly examine the intersection between financial inclusion and social determinants of health. After that, we conducted a co-occurrence network analysis, thematic map analysis, and thematic evolution analysis in BiblioShiny, a web-based platform for the bibliometrics R package. We set a minimum keyword co-occurrence of 10 and a cluster size of 10, which resulted in 6 clusters. Here we can see that we have six clusters. The first one, the first cluster title is about microfinance and poverty alleviation. The second one about digital financial inclusion and fintech innovation. The third one is about emerging trends in financial and health inclusion. The fourth one is about public health policy and health economics. The fifth one is about a systematic review on COVID-19 and mental health. The last one is about central bank digital currencies and blockchain technology. In figure 6, we can see here that thematic map of research themes is divided to motor, niche, emerging or declining, and basic, based on keyword co-occurrence analysis. We can see here in niche themes that it contains central bank digital currency, blockchain, CBDC, financial inclusion, fintech, and digital financial inclusion. In basic themes, we can notice that this group contains social determinants of health, inclusion, health equity, and poverty, microfinance, health. Through table 7, we can notice here thematic clusters divided to each cluster divided to top 3 keywords, and I identified between centrality, page rank, centrality to each cluster, density, cluster frequency, and in the last column, I make a small interpretation to each cluster. In the table 8, I put the future research directions to each cluster of our study. Here we can notice that the first cluster, the future research question, what role can technology such as mobile banking, blockchain, play in scaling microfinance services to achieve sustainable development goals in low and middle income countries. Cluster 2, how can digital financial inclusion initiatives be designed to address the digital literacy gap and infrastructure's limitation in underdeserved population? Cluster 3 here is a sample, but every cluster in the main paper have 4 questions. Cluster 3, how can social determinants of health be incorporated into financial inclusion policies to promote health equity and reduce disparities among vulnerable groups? Cluster 4, what are the cost effectiveness implications of integrating public health policies with border development goals such as poverty reduction and gender equity? Cluster 5, how can mental health services be integrated with border public health initiatives such as universal health coverage to reduce disparities and improve outcomes? The last cluster, what are the potential risks and benefits of integrating blockchain technology into healthcare supply chains, particularly for essential medicines in low-income countries? Our results here brief in 6 points. The first one, we reached to that comprehensive review on the link between FI and SDH found no direct integration despite 4,021 applications. Point 3, FI enhances economic stability, poverty reduction, and success to services, but remains disconnected from mainstream SDH research. Point 3, existing studies are fragmented, with FI and SDH mostly studied separately. Point 4, clear synergy potential. FI, like digital finance, microfinance, insurance, can reduce health inequities. SDH frameworks can benefit from economic financial indicators. Point 5, gap present both a challenge and an opportunity. Okay, the last one, advancing financial inclusion and social determinants research is vital for inclusive, resilient system and achieving the SDG especially in low and middle income countries. Thank you for your attention. Hello?
Hello, hello, Dr. Eliza.
Hello?
Masa. I'm very sorry. Dr. Masa. Thank you so much, Dr. Masa. Hello. Am I audible?
Hello? Hello,
Yeah.
yeah. I'm listening
Yeah.
to you.
Thank you so much, Dr. Masa, for the
You're
study that you
welcome.
shared with us. I
You're
think it
welcome.
was really insightful and really advantageous, like for doing this kind of in terms of management. I think it will help a lot of hospitals, clinical setups to understand what is the regarding the social determinants as well as the financial inclusion. So I think it's of
Yes.
great importance. I would like to open this presentation for discussion. Any questions or queries, please feel free to ask Dr. Masa. Doctor, I would like to inquire something about when we are talking about the global review. What is the kind of status that you would like to share in the Middle East? If you talk about the Middle East, what will be your response? Like, what is the kind of
Hello?
option? Hello?
Hello?
Hello? Yeah, you're audible, doctor. Hello? Hello? I think there is some technical difficulty. Hello?
Hola.
I,
Hi.
hello? I think there is some technical difficulty with Dr. Misa right now due to some internet connection. If she joins back, we can continue this thing. Okay, I think there is some problem. We will just move on to the hello.
Hello?
Yes, doctor.
Hello?
I'm very sorry. There was some difficulty. I think there is some technical difficulty. I apologize on the behalf of really sorry for the difficulty. And I would like to move on to our last presentation. Actually, I apologize that our last speaker for the day, Mrs. Lina Sadeh Boshe from Al-Quds University, Palestine. She is unable to attend the conference in person. Therefore, we would like to present her presentation over here. So her research focuses, the speaker, her research focuses on the knowledge, attitudes, and practices of physicians in primary healthcare settings in Jordan. And the topic for her presentation is titled The Knowledge, Attitudes, and Practices of Physicians at Primary Healthcare Centers or Clinics Regarding the Right to Health in the district of Ramallah Al Bereh in the year 2014. So we'll be playing the presentation over here. Kindly go through it. Any doubts or any queries can be discussed later at the end of the presentation. Thank you.
Hello?
Hello? So that was the end of her presentation, and that marks the conclusion. I would like to conclude the day 3 of our conference, as well as the end of the 3-day conference that was held over here in the UAE. And as to conclude, I would like to thank all the speakers who took their precious time to come here and explain their insights and present their findings of their studies. Thank you so much, all our lovely speakers. And I hope this was a very fruitful day for each one of us, as well as all the clinicians out there, to have attained really good information about the topics that were discussed today. And I also thank the presenters who did their job really well on behalf of UCG. And this marks the end of our conference here. Again, thanks to all of you. Have a great day ahead. And this is me, Dr. Onisha, signing off. Thank you so much for being part of this conference again. And it was my pleasure to be a speaker, as well as I had a great time at the conference too. So thank you. Thank you so much.